get us into the question 51, then we zoom in. Thank you.
Um, Good evening, teachers. Good evening, colleagues. I'll be taking question 51 to 55. So, a 44-year-old man with diabetes and a strong family history of premature coronary artery disease underwent cardiac evaluation because of episodes of exertional substernal chest pressure. His resting ECG demonstrated normal sinus rhythm and borderline left ventricular hypertrophy. During exercise, myocardial perfusion imaging, he developed his typical chest discomfort and stopped at 3 minutes 20 seconds of the standard Bruce protocol at a peak heart rate of 105 beats per minute, which is 60% of age predicted maximal heart rate. The systolic blood pressure decreased by 20 millimeters of mercury at peak exercise. Based on the myocardial perfusion images in figure 1.11, which of the following statements is true? A. There is no evidence of reversible ischemia. B. Transient dilatation of the left ventricle after exercise stress is absent. C. The increased lung uptake of the radiotracer evidence on stress imaging is a normal physiologic response. D. There's an increased right ventricular tracer uptake on the post-stress image, which is a specific marker for multivessel or left main coronary disease. E. The test result is inconclusive owing to failure to achieve the target heart rate. So basically, for myocardial perfusion imaging, when you have the data, there are some things you're looking out for. If there's a perfusion defect or not. If there's a perfusion defect, you want to know if the perfusion defect is reversible or fixed. And if it's fixed, you want to know if it's a myocardial infarction or an artifact. And this can be differentiated using a gated ECG to the perfusion images. And an area of infarct would have an abnormal motion or wall thickness, while for artifacts, the wall motion and wall thickness will be normal. Now, if the perfusion is normal both at stress and at rest, they are equal. It means the myocardium is normal. If, however, during stress, there is a defect that is not present at rest, it means there is myocardial ischemia. So when there's an area of defect, perfusion defect, you want to know the site, the size, the severity, and if it's reversible. Now, looking at this image now, to know the site for the short axis, which is the top images, where it's written SA, that's the short axis. You'll notice that at the anterior part, which is the top part of during the stress, there's a defect when you compare to the rest image below. Then, if you also look at the horizontal long axis. You also see that at the posterior side, there's also a defect when you compare the stress and the rest images. Thank you very much, Eugene. Now for the vertical long axis, you also see a defect at the septal area. So for location of this defect, we know that involves the anterior part of the apex, the posterior aspect, and the septal aspect. So using the coronary artery territory, you know that the right coronary artery is involved, and then the left anterior descending artery are involved. Severity, for the severity of this defect, you can use the different segments. If 10% of a segment is involved, it's mild. If up to 10 to 20%, it's moderate. If 20 to 40% is severe, and then anything greater than 40% is said to be extensive. That's for the segmental. But this is said to be subjective based on the observer. So there are other ways to know the severity, and this involve one, the transient ischemic dilation. That's the TID that is written, the ratio. And this TID is when you compare the left ventricular cavity at during stress and at rest. So the ratio you get, that's the transient ischemic dilation. Usually for single photon emission computer tomography that expects myocardial perfusion, it's expected to be less than 1.22. And then for positron emission tomography that expects myocardial perfusion imaging, it's supposed to be less than 1.11. For this patient, it's greater than these values. That's 1.22 and 1.19. So which means, and when this value is greater than this cutoff point, it means there's either an extensive left anterior descending coronary artery involvement or a multivessel involvement. Now, another way to know the severity is if there's extracardiac perfusion defects, like increased uptake in the lungs, which this patient has. If you look at this image at gated stress and gated rest, you will see that the image to the right, that's right bottom corner, you notice that the uptake at rest is more. And this is because during stress, there's an increase in left ventricular pressure, which eventually leads to a rise in the pulmonary venous pressure, which causes reduced clearance of the radiotracer element from the lungs, which will now cause increased uptake. Another way you can know the severity is if there's involvement of the right ventricle. So if you look at this other image, which is the polar image, the blackout map. If you look at the first image to your left, which is what was recorded, this gated stress recorded, that's the perfusion for this patient that was recorded. Now, if you look at the bottom corner around the region of the right coronary artery, which supplies the right ventricle, you'll notice that it's brighter than this gated stress reconstructed, which is the next image. Dr. Eugene, I don't know if you can mark. Yes, this reconstructed gated stress. Yes. So this is supposed to be the normal. But if you notice, if you look closely at the bottom part, just under bottom left part, just under this blackout area, you'll notice that that area is brighter than this expected. This place that this other image compared to this other image, Dr. Eugene marked yellow. So you're comparing red to yellow. Yeah, thank you very much, Dr. Eugene. So if you look at this area where Dr. Eugene is marking now compared to this other area, you'll notice that the one on the left, that's the red, in the red circle, is brighter, which means there's an increased uptake in the right ventricle for that. And this is also a prognostic marker. Now, for the third image on this polar map, usually for perfusion, if perfusion is less than 2.5 standard deviation of normal, which the normal is expected to be this yellow circle Dr. Eugene has marked. It's marked black. However, if it's within, let's say it's low, but within, let's say 1 to 2 standard deviation below the mean, it's marked as the hashtag. And this hashtag, what it connotes is that that area has reversible ischemia. So now can we go back to the question so that we can just answer the questions? Thank you very much, Dr. Eugene. So there's no evidence of reversible ischemia. That's false because from the polar map or the blackout map I showed there, the area there was marked with the hashtag. So it means it's a marker of reversibility. So that makes it false. B, transient dilatation of the left ventricle after exercise is absent. From the transient ischemic dilation ratio, I told you that it's supposed to be less than 1.22 if it's SPECT and 1.19 if it's PET, myocardial perfusion imaging. So any value above this means there's transient dilatation of the left ventricle after exercise. So that is also false. C, the increased lung uptake of the radiotracer evident on stress imaging is a normal physiologic response. This is false because it's as a result of the increased pulmonary venous pressure. That's why there's increased uptake. So it's a pathological process, not physiological. D, there's an increased right ventricular tracer uptake on the post-stress image, which is a specific marker for multivessel or left coronary artery disease. I had explained before that involvement of the right ventricle is a marker of either a multivessel disease or extensive left main coronary disease. Then that's why that is true. Then the test results are inconclusive owing to the failure to achieve target heart rate. This is false because this test was, it's not just that the patient didn't meet the criteria. The chronotropic defect is a marker of a positive stress test. And then in addition, the patient also had the blood pressure effect for a positive stress. We know that a fall in blood pressure of greater than 10 millimeters of mercury at the peak of exercise is a marker for a positive stress test. So I don't know if there's any question or any contribution pertaining this question 51. Thank you.
Thank you very much, Dr. Mohammed. So our colleague who asked the question yesterday, if you are still on, can ask your question.
I'm okay. He has explained it.
Oh, okay. Thank you very much. So Dr. Mohammed, you can go to the 52. Thank you.
Okay. Question 52. Which of the following statements about the aortic valve Doppler flow tracing shown in figure 1.12 is true? Okay. So looking at this image, the velocity is around about 5. I'll just approximate to 5. And there's also a coexisting aortic regurgitation. So using the Bernoulli equation of 4 v square, I expect the aortic velocity peak maximum velocity to be around about 100 or slightly less than 100. And the mean aortic velocity to be about 0.6 times the peak should be around 60. So Dr. Eugene, can we go to the question so that I can just answer the questions? Okay. So A, the probability of critical aortic stenosis in this patient is low. So we know that using the aortic velocity, the cutoff value is 4 meters per second. Any value above this is suggestive of critical aortic stenosis. Other echocardiographic criteria is an area of less than 1 centimeter square and a mean pressure of greater than 40. So for this patient, the mean is estimated to be around 60 and the peak is around 100. So the probability of critical aortic stenosis in this patient is low, is false. B, the estimated peak transaortic valvular gradient is 90 to 100. I'll say this is true using the Bonelli equation, like I explained earlier. The aortic insufficiency is severe. Looking at that image, the values are not there to calculate the aortic pressure half time, but the slope is gradual. So the slope is gradual. So I would, this should be around mild to moderate, not severe. So that makes C false. Option D, based on the Doppler findings, premature closure of the mitral valve is likely. This is false because usually premature closure of the mitral valve will occur in when there's severe aortic regurgitation, and this will cause a rapid rise in the left ventricular pressure during diastole, causing a premature closure of the valve. E, the echocardiogram likely reveals normal left ventricular wall thickness. This is false because with the severe aortic stenosis, I expect that there will be a left ventricular pressure overload, and this would is most likely going to lead to left ventricular hypertrophy. So this is false. I don't know if there's any clarification or question or contribution to the question.
Hello, good evening.
Yeah, good evening, Prophet. We can hear you.
Yes, okay, thank you. Thank you very much for answering that question. I just wanted to add, when you look at the continuous wave jet, aside the velocity being high, other things that would make you suspect a severe aortic stenosis is that you realize that the jet is not peaked, it's rounded. And that tends to happen because in aortic stenosis, you have the slow rising pulse. So because of that, the peak is not a sharp peak, right? It's well rounded. And then the jet is also wide. I'm not sure what exactly the measurement is to consider it's wide. But if you have a normal or a mild to moderate aortic stenosis, from the beginning of the aortic forward flow jet to the end is narrower than when you have a severe stenosis. So those are some other features that you can look out for to help you tell that you're dealing with an advanced aortic stenosis. Thank you.
Thank you very much for the contribution. Thank you. Question 53. Which of the following statements regarding abnormalities of the extremities in cardiac condition is false? A. Arachnodactyly is associated with Marfan syndrome. This is true. Arachnodactyly is it's said to be slender fingers, and it's can be demonstrated using the Sternberg sign or the Walker-Murdoch sign. For the Sternberg sign, usually we would ask the patient to hold the thumb towards the ulnar part of the little finger. It's positive if the patient is able to fold the finger and then the tip of the tongue and the thumb extends beyond the ulnar border of the little finger. While the Walker-Murdoch sign, you ask the patient to use do like a pincer grip round the opposite wrist, and for patients with Marfan's, they are able to wrap their thumb and little finger round the wrist with significant overlapping of the two fingers. So since this is a true statement, that makes the answer false. A thumb, option B, a thumb with an extra phalanx commonly occurs in Turner syndrome. This is false. For Turner syndrome, the skeletal abnormalities usually that they usually will have is web neck, short foot metacarpal or metatarsal, and then cubitus valgus, and that's basically what they would have. So since this is false, this makes the answer true. Quink's sign is typical of chronic aortic regurgitation. This is true. Osler nodes are tender erythematous lesions of the fingers and toes in patients with infective endocarditis. This is also a true statement, so that's false. Differential cyanosis is typical in a patient with patent ductus arteriosus with a reverse shunt. This is true. Normally in PDA, there's usually a left to right shunt, but with continuous flow of blood from the left to the right, with time, there's an increase in pressure on the right, leading to flow of blood from the right reversal of the shunt as a result of the increased pulmonary arterial pressure. This leads to a flow of deoxygenated blood from the right to the descending aorta, bypassing the lungs. So the parts that are distal to the flow would have deoxygenated blood, while the proximal part receive oxygenated blood. So this can be confirmed using a pulse oximeter. Any difference in the oxygen saturation greater than 5% indicates differential cyanosis. So because this is a true statement, that makes it false. So for Question 53, the answer is B. So I don't know if there's any clarification or contribution.
Sorry, please. I didn't get the last thing you said. How many percent shows the differential cyanosis, please?
5%. Differential greater than 5%.
Thank you.
You're welcome. Question 54. Which of the following is not commonly associated with the disorder illustrated in figure 1.13? A, tricuspid regurgitation. B, patent foramen ovale. C, Wolff-Parkinson-White syndrome. D, systemic hypertension. E, atrial fibrillation. So if you look at this image, it's an echocardiographic image of the heart showing the 4 chambers of the heart. And if you look at it closely, you'll see that the tricuspid valve is ventricularly displaced. It's more into the ventricle. And the leaflets of the tricuspid valve are elongated. There's also poor coaptation of the tricuspid valve. And then obviously the right atrium is larger than even the right ventricle. There also seems to be an interatrial defect, but because there's no obvious, there's no color Doppler there, we can't objectively say there is a defect or not. So for these patients, because of the poor coaptation, even though there's no Doppler, the option A, tricuspid regurgitation, is true. Option B, patent foramen ovale, there's a defect, interatrial defect, that it's there. But of course, there's no color Doppler to objectively confirm that. Then option C, Wolff-Parkinson-White syndrome, because of the large atrium, the patients with Epstein's anomaly tend to have accessory pathway, which is usually on the right, and they will have Wolff-Parkinson-White. So this is usually present in them too. Atrial fibrillation, option E, atrial fibrillation. The increase in the size of the right atrium also predisposes them to atrial fibrillation. I said that most of them would either have atrial fibrillation or atrial flutter. So option D is the true option because Epstein's anomaly is not associated with systemic hypertension. Any question or contribution? Okay, question 55. Which of the following statements is true regarding the echocardiographic evaluation of suspected infective endocarditis? Vegetations of the mitral valve typically occur on the ventricular aspect of the leaflet. This is false because usually infective endocarditis is said to occur at the side of lower pressure, so across the valve. So if for the mitral valve and tricuspid valve, the atrial side has lower pressure. So it's said that for mitral and tricuspid, effective endocarditis appears more on the atrial side, while for the aortic and pulmonary, it occurs more on the ventricular side. So for this option, for mitral valve, the answer is false because it occurs more on the atrial side, which is the lower pressure side of the chamber. Option B, the sensitivity of transthoracic echocardiography for detection of vegetation is less than 70%. While reading, Braunwald'S actually quoted 63%, but other books quoted between 60 to 65%, which is actually less than 70%. So this option is true. C, after successful antibiotic therapy, previously detected vegetation should not be visible by echocardiography. This is false if the vegetations are still persist even after antibiotic treatment. They can still be visible. Option D, functional and structural consequences of valvular infection are rarely observed by transthoracic echocardiography evaluation, such that a transesophageal study is always mandatory. Yes, the sensitivity of transthoracic, like I said, is about 60 to 65%, while for the transesophageal, it's more sensitive, 94 to 100%. But it said that for patients that have a normal echocardiography, where there's no structural, there's no flow abnormality, the valves appear normal and there's no regurgitation, doing a transesophageal doesn't add any sensitivity to it. So that makes it false. Then thoracic echocardiography and transesophageal echocardiography have similar sensitivities for detection of myocardial abscess formation. This is false because transesophageal is more sensitive in detecting myocardial abscess formation. I don't know if there's any question or contribution pertaining question 55.
Thank you very much, Dr. Mohammed. We are grateful. So we move to question 56 to 60. So if our colleague is on, Dr. Freedom Eneho, if you are on, kindly continue from 56 for us.
Okay. Good evening, our teachers, colleagues, our teachers, consultants, fellows and colleagues. So I'm taking questions 56 to 60. So for question 66, the question is, which of the following statements is true regarding examination of the arterial pulse? A, A reduced volume brachial pulse with a late systolic peak is the most characteristic arterial finding on physical examinations in patients with aortic stenosis. B. A bispherous pulse is characterized by a systolic then and then a diastolic peak and is typical of mixed mitral valve disease. C. The carotid artery is the blood vessel used to best appreciate the contour, volume, and consistency of the peripheral vessels. D. In coarctation of the aorta, the femoral pulse demonstrates a later peak than the brachial pulse. D. The normal abdominal aorta is palpable both above and below the umbilicus. Essentially, this question is testing our knowledge on examination of the arterial pulse. Pulse abnormalities are variations in the normal characteristics of the pulse. It includes variations in the rates, characteristics such as the rates, rhythm, the strength, and contour. The abnormalities can provide significant clinical insights into various cardiovascular or systemic conditions. Some of these conditions, like we know, includes abnormalities in rates, such as bradycardia and tachycardia, with their attendant causes. Other abnormalities includes abnormalities in the reading, and some patients might have irregular pulse, which can be caused by atrial fibrillation, premature ventricular contractions. Then other pulse abnormality that we know includes pulsus paradoxus, which we've discussed earlier, is defined as an exaggerated decrease in systolic blood pressure of more than 10 liters of mercury during inspiration, which can be observed as a weak or absent pulse. And usually, like was mentioned in our previous discussion, and the abnormal pulsus paradoxus is actually detected during while the BP is being measured. It's not during measurement of the blood pressure or the arterial blood pressure. Then other pulse abnormality includes pulsus alternans, in which there is a regular rhythm with alternating strong and weak pulses. The causes of pulsus alternans includes advanced heart failure, amongst other causes. And then pulsus bisferens is a pulse with two distinct peaks per cardiac cycle, one in systole, then another in diastole. One in systole, another in diastole. The causes include aortic regurgitation, patients with hypertrophic obstructive cardiomyopathy, severe aortic stenosis combined with aortic regurgitation. Also, some patients can present with weak or thready pulses, in which the pulse is usually described it as being faint and difficult to palpate. While in some cases, some patients can present with collapsing pulse, which is usually described as a strong rapid pulse that quickly collapses with palpation and is often described as water hammer due to its forceful contraction. Then there is pulsus bigeminy, in which a pulse is characterized by a normal beat followed by a premature beat. There's a normal beat followed by premature beat, thereby creating a regular repetitive pattern. And it's also worthy of us to note that another form of pulse abnormality includes pulsus parvus et tardus. The the name, the pulsus parvus, the parvus there means a weak pulse, while the et tardus means delayed pulse. So for pulsus parvus et tardus, the pulse has a reduced volume initially, indicating that less amount of blood is being pumped through an artery per beat, often resulting in a weaker or more difficult to palpate pulse. While the tardus refers to the delay in that's the rise in arterial pulse when there is a delay in the rise of the arterial pulse, meaning that the time from the heartbeat to the peak of the pulse is longer than normal. So I think we'll go back. Then the conditions that can cause pulsus parvus et tardus includes aortic stenosis, subaortic stenosis, in patients with aortic regurgitation, then hypertrophic obstructive cardiomyopathy. The volume and contour of arterial pulse depends in part on its left ventricular stroke volume. The ejection, the volume and contour of the arterial pulse depends in part on some factors which include left ventricular stroke volume, the ejection velocity, and the compliance with the capacity of the arterial system. Pulsus parvus et tardus, like I mentioned earlier, is a small pulse with a delayed systolic peak, which is characteristically seen in severe aortic stenosis and being appreciated by palpating the carotid artery rather than the peripheral vessel, such as the brachial artery. In patients with severe aortic stenosis and congestive heart failure, the delayed upstroke is not usually evident. So it's the parvus component that is usually felt. So I think now we can go back to the question. So now we'll go back to the question. Which of the following statements is true regarding examination of the arterial pulse? 1. A reduced volume brachial pulse with a late systolic peak is the most characteristic finding on physical examination in patients with severe aortic stenosis. This is wrong. This is not true. And B, a bispheric pulse is characterized by systolic and then a diastolic peak and is typical of mixed mitral valve disease. No, we talked about this that is seen in patients with mixed aortic and stenosis and regurgitation. Then the carotid artery is the carotid artery is the blood vessel used to best appreciate the contour, volume, and consistency of peripheral vessels. So this is wrong. The carotid artery is not used to test the contour and the volume and consistency of the peripheral vessels. Instead, the brachial artery is used to best appreciate that. Then D, in coarctation of the aorta, the femoral pulse demonstrates a later peak than the brachial pulse. This is the right answer. In patients with coarctation of the aorta, the femoral pulse develops a later peak than the brachial pulse. Then E, the normal abdominal aorta is palpable above and below the umbilicus. No, the abdominal aorta, sorry, I didn't mention that initially during the presentation. The normal abdominal aorta is usually palpable only above the umbilicus. If you are palpating it below, then the patient is having some form of aortic aneurysm. So that's for question 56. We have comments, contributions, and questions. If we don't have, I'll have to continue with 57.
Sorry, so I just have one comment. So thank you very much. When you were explaining, you mentioned that the Bispherians pulse has two peaks, one in systole and one in diastole. However, there are two different ones. There's Bispherians and there's dicrotic. The Bispherians, with that one, both peaks are in systole, and that's the one that occurs, as you said, in aortic regurgitation. But the dicrotic pulse, that one is one in systole, one in diastole, and it's associated with low output states, like what you may have in shock or severe LV, left ventricular disease, etc. So I just wanted to highlight it that experience both peaks are systolic, but dicrotic, one is systolic, one is diastolic. Yeah, thank you.
All right, thank you so much. Thank you so much. So the next question is question number 7. Which of the following statements...
Before you go to the next question, I wanted to say something.
Okay.
Before you move on to the next question, option C says the carotid artery is the blood vessel that is best used to appreciate the contour, volume, and consistency of the peripheral vessels. What I wanted to say is that the brachial artery, like you said, is actually for volume and consistency, but the carotid artery is actually best to assess the contour because it's the most similar to the aorta. That's just what I wanted to add. So that's why that option is actually false.
Option is false. All right. Thank you so much.
I don't know whether you got what I said. Thank you.
Question. Yes, I got it. Thank you. Yeah, question 57. This is testing our knowledge on cardiac catheterization. Okay, which of the following statements regarding cardiac catheterization is true? A. When cardiac catheterization is performed from the groin, the risk of retroperitoneal hemorrhage is decreased. Sorry, and Chief Eugene, I don't know if you can go to the other side. I can't. I don't know if I'm having some delays here.
I think there's a delay from your end. I've moved, so I'm sure it will come soon.
Okay. Not still seeing it yet.
Please, is anyone else seeing it? Hello?
Just go to previous one and come back. Let me see whether I can see it. Hello?
I've moved back. Do you see it now?
Yeah.
Just go to this one and let me see whether it will change here. Okay. Okay, I can see this.
So I've moved back to
okay.
them.
Okay. Let me start all over again. Which of the okay?
I want to
I
start.
wanted to take it all over again. Yes,
okay.
yes. Okay. Which of the following statements regarding cardiac catheterization is true? A. When cardiac catheterization is performed from the groin, the risk of retroperitoneal hemorrhage is decreased. Okay. The risk of is decreased when the femoral artery puncture is made above the inguinal ligaments. B. An international normalized ratio of less than 2.2 is acceptable for radial artery catheterization. Then C. Patients with shellfish allergy are at greater risk of intravenous contrast reactions than patients with other food allergies. D. Pseudoaneurysm formation is more likely to occur if the femoral artery puncture is made above the bifurcation of the femoral artery. So essentially, cardiac catheterization is a minimally invasive diagnostic and interventional procedure which is used to evaluate and treat cardiovascular conditions. It involves inserting a thin, flexible tube into the blood vessels and guiding it to the heart. It provides information about the function, blood flow, and vascular anatomy. Indication of cardiac catheterization includes for diagnosis of heart conditions like coronary artery disease, congenital heart disease, valvular heart disease, amongst others. Can also be used in assessing heart function, thereby measuring blood pressure, evaluating cardiac outputs, like we discussed previously, using the thermodilation method and fixed method, analyzing the blood gases. Then can also be used for cardiac interventions like coronary angioplasty and stent placements, repair of congenital heart defects, pacemaker defibrillator implantation. In preparing a patient for the procedure, you take a detailed medical history and physical examination. You want to know the patient's renal function because the patients will be given contrast to avoid contrast use nephropathy. You want to do a coagulation profile whether the patient is at risk of bleeding. Then for some patients, want to do an echo and probably a stress test correction for a procedure that will give you an idea of what the pathology may be before even carrying out the procedure. Then the patient usually asked to fast for about 6 to 8 hours before the procedure. Then if patient is on anticoagulant medications previously, they are asked to discontinue such medications. Then the sites that usually the commonest site that's used is that the femoral artery and the radial artery. Then sometimes they may also use the brachial artery. It's usually used to numb the site of insertion, following which a small incision is made. The catheter is advanced under fluoroscopic guidance to the heart. Like I said previously, it can be used for coronary angiography, pressure measurements, and then determining the oxygen saturation, checking oxygen levels within different parts of the heart. It usually takes about 30 to 60 minutes for diagnostic procedures. Then for intervention, it can take between 1 to 3 hours. And usually post-procedure, the patient's vital signs are measured, measure the blood pressure, the heart, the insertion site for bleeding. Then you also observe further complications like hematoma formation. Then the patient can be asked to come for follow-up. The common complications that can occur during post cardiac catheterization includes, it can even occur during the procedure, includes bleeding or hematoma at the access sites. However, in order to decrease the risk of retroperitoneal hemorrhage when using the femoral artery approach, the puncture of the common femoral artery should be made below the inguinal ligament, because if there is any form of bleeding, you can actually apply pressure at that point. However, if it is made above the puncture should be made below the inguinal ligaments, but the site should be proximal to the bifurcation of the superficial femoral and profunda arterial branches. If the puncture site is proximal to inguinal ligaments, like I said earlier, it is difficult to establish hemostasis. However, if it is below, you can apply manual compression to secure hemostasis. However, if the puncture site is distal to bifurcation, there is an increased risk for the formation of pseudoaneurysm. Then other complications include infection at the site. Then some patients might react to the contrast that's being used. Then it is said that patients with a history of shellfish allergy are not usually at a higher risk of contrast media reactions than patients with other food allergies. Less common risks that can occur includes damage to the vessels or dissection. Then some patients might develop arrhythmia, while there can also be perforation of the vessel. Then for patients on warfarin, the international normalized ratio should generally be less than 1.8 at time of procedure to minimize bleeding when the femoral artery approach is used. However, for patients if the radial artery is the access site, that's to be used for the surgery for the procedure, an INR of less than 2.2 is usually you advise that the INR for that patient should be less than 2.2. So we'll go back to the question at this point. Sorry. So question one. Okay. Dr. Eugene, please can I take question again so that we'll just get the answers and move on? Okay. So which of the following statements regarding cardiac catheterization is true? A. When cardiac catheterization is performed from the groin, the risk of retroperitoneal hemorrhage is decreased when it's decreased. Sorry. Please, can you move it? Okay, thank you. It decreases when femoral artery puncture is made above the inguinal ligaments. This is false. We said the risk of peritoneal hematoma is increased when the puncture is made below the inguinal ligament, proximal to the site of bifurcation of the superficial femoral artery and the profunda branch. Then question B. An international normalized ratio of less than 2.2 is acceptable for radial artery catheterization. This is the correct option for this question. Usually, if the radial artery catheterization is to be done, the INR of less than 2.2 is acceptable. Then patients with shellfish allergy are at greater risk of intravenous contrast reactions than patients with other food allergies. This is false. They are not at greater risk of intravenous contrast reaction. Then D, pseudoaneurysm formation is more likely to occur if the femoral artery puncture is made above the bifurcation of the common femoral artery. This is false, as we've mentioned earlier. So that's for question 57. If there are comments and questions, you can take them at this point. In the absence of none, I'll move to question 58. Okay. So question 58. Which of the following statements regarding the use of cardiopulmonary exercise testing in patients with congestive cardiac failure is correct? A. A peak oxygen consumption of less than 14 mL per kg per minute identifies patients who will benefit from cardiac transplantation. And B. Patients with ejection fraction less than 20% consistently have peak oxygen concentration less than 10 ml per kg per minute, and exercise testing is of little utility in this population. And C, the exercise limitation in severe heart failure is due primarily to an inability to raise the heart rate. D, exercise training in congestive patients improves functional capacity but has no effect on abnormalities of autonomic and ventilatory responsiveness or increased lactate production. E, results of exercise testing are rarely useful when making clinical decisions about heart failure patients, such as timing of cardiac transplantation. So this question is essentially testing our knowledge on cardiovascular exercise testing. And exercise testing usually plays a crucial role in diagnosis, prognosis, and management of patients with heart failure. It helps to evaluate the functional capacity, also helps in assessing the severity of symptoms and monitor the effects of treatment in patients with heart failure. The indications for exercise testing in heart failure includes one, to assess functional capacity. It also helps in predicting outcomes and can be used to assess severity of heart failure, thus helping in prognosis. It can help in determining patients that will have good or worse outcomes, and also help in assessing response to treatment following therapeutic intervention. It can help in evaluation of arrhythmias. The types of exercise stress testing includes the treadmill testing, the the psychoergometry, then the cardiopulmonary exercise testing, which is a more detailed form of exercise testing that measures oxygen uptake, carbon dioxide output, and ventilative parameters. In interpreting the cardiopulmonary exercise testing results, there are some factors that are usually considered. One, you look at whether the patient has reduced exercise capacity. Usually in heart failure, there's a marked reduction in exercise capacity, which can be due to decrease, which is likely due to decreased cardiac output and impaired skeletal muscle function. Then you also want to look at whether the patient has a normal or an abnormal hemodynamic response. Want to whether a patient has a normal or an abnormal hemodynamic response. Want to check for the oxygen uptake kinetics, yeah, whether the patient has some exercise induced arrhythmias also. The In patients with heart failure with ejection fraction, they usually show much profound reduction in exercise capacity. However, patients with heart failure preserved ejection fraction may reveal impaired diastolic filling, reduced cardiac output, and decreased exercise tolerance despite normal ejection fraction. Even though the ejection fraction is normal, they might also have reduced exercise tolerance. It has been demonstrated that peak oxygen consumption and aerobic threshold measured during cardiopulmonary exercise testing, it provides independent prognostic information in populations of patients with heart failure and are usually superior to measures such as ejection fraction or functional class in predicting outcomes. Patients with severely depressed ejection fractions exhibit a wide range of exercise capacity, with some being near normal, meaning patients with even reduced ejection fraction, they can have near normal exercise testing, exercise functional capacity. And exercise testing can be critical to quantifying the true functional limitation. A peak oxygen consumption of less than 14 ml per kg per minute has been shown to predict more survival, and it has also helps it also helps identify a population in whom mortality is improved by cardiac transplantation. Usually said that peak um, oxygen consumption, the normal should be between 14 ml per kg per minute to 20 ml per kg per minute. A patient at this level of impairment, that's level less than 14 ml per kg per minute, demonstrates or develop a profound exercise limitation with maximal exercise capacity being required for activities such as walking, usually for activities like walking, playing golf, or raking leaves. Maximum exercise um, capacity is required. So patients with peak oxygen consumption of less than 14 ml per kg per minute can may not be able to perform or undergo a complete stage 1 on the standard use protocol. However, patients who achieve a peak oxygen consumption of greater than 14 ml per kg per minute usually have a mortality rate similar to patients who have undergone cardiac transplantation, and they are less likely to benefit from any intervention because their peak oxygen consumption is within usually within the normal limits. Though in one source that I saw said normal is between 14 to 20 ml per kg per minute. Usually greater than 20 ml per kg per minute from that source is said to be normal. And this exercise limitation in patients with congestive heart failure is correlated most strongly with alterations in skeletal muscle metabolism. Then abnormalities in autonomic and ventilatory responsiveness increases lactate production, particularly when there is problem with ventilation perfusion. So the delta muscles will, instead of using aerobic metabolism, convert to anaerobic, thereby leading to lactate production. So we'll go back to the question. Which of the following statements regarding the use of cardiopulmonary exercise testing in patients with cardiac failure is correct? A. A peak oxygen consumption of less than 14 ml per kg per minute identifies patients who would benefit from cardiac transplantation. From the little talk I just gave, this option is correct. Patients with peak oxygen consumption of less than 14 ml per kg per minute that are usually thought to benefit from cardiac transplantation because these patients usually have a very high level of impaired functional capacity. B. Patients with ejection fraction less than 20% constantly have peak oxygen consumption less than 10 ml per kg per minute, and exercise testing is of little utility in this population. Usually, like I mentioned earlier, the EF is not usually a factor because it said that patients with near normal EF, like patients with heart failure possess ejection fraction, they can have near normal functional exercise, normal exercise functional capacity. Then C, so the option B is false. C, the exercise limitation in severe heart failure is due primarily to an inability to increase the heart rates. From the little talk that we had, this option is false. Then D, exercise training in congestive heart failure patients improves functional capacity, but has no effect on abnormalities of autonomic and ventilatory responsiveness or increase lactate production. This option is false. Then E, results of exercise testing are rarely useful when making clinical decisions about heart failure patients, such as timing of cardiac transplantation. This option is false because we said that patients with peak oxygen consumption less than 14 ml per kg per minute usually benefits from cardiac transplantation. So option, 59. Option 59 in in which of the okay thank you, Dr. Eugene. Thank you. 59, I think, has left. In which of the following clinical scenarios would an alternative imaging modality be preferred over magnetic resonance imaging? So in which of the following clinical scenarios would an alternative imaging modality be preferred over magnetic resonance imaging? A. Diagnosis of ion overload cardiomyopathy in a pediatric patient with beta thalassemia major and congestive heart failure. B. Diagnosis of arrhythmogenic right ventricular cardiomyopathy in a 24-year-old man who recently survived a cardiac arrest. C. Diagnosis of aortic coarctation in a 17-year-old girl with hypertension and radiofemoral artery delay on physical examination. D. Serial evaluation of left ventricular function in a 54-year-old woman with metastatic breast cancer receiving doxorubicin chemotherapy. E. Diagnosis of renal artery stenosis in a 78-year-old man with refractory hypertension. Okay. It is thought that it is said that cardiac magnetic resonance imaging is a powerful non-invasive tool that is used for diagnosis of several cardiac and vascular conditions. Cardiac magnetic resonance imaging provides an outstanding imaging quality and reproducibility as well as attractive features. It does not need ionizing radiations, unlike we see in patients, all the patients exposed to CT, chest X-ray, and it also doesn't need iodinated contrast. Cardiac magnetic resonance imaging is well suited for identification of congenital heart lesions cardiac tumors, assessing of myocardial infarction, and viability, and characterization of cardiomyopathies. T2 imaging in cardiac MRI is thought to be a well-validated technique for measuring tissue iron content. It's said to be used to identify iron overload in patients with beta thalassemia and to guide chelation. Cardiac magnetic resonance imaging, it defines the structure and function of the right ventricle and is useful in diagnosis of arrhythmogenic right ventricular cardiomyopathy. It's also helpful in evaluation of stenotic and Gojtan valves when echo windows are inadequate. The use of cardiac magnetic resonance imaging for pharmacologic myocardial perfusion imaging and lobotomy stress testing is another important clinical application when compared with nuclear imaging. Cardiac magnetic resonance imaging is not limited by attenuation artifacts like seen in, I think we talked about it in that's seen in patients with that has specs. Then it also has a higher spatial resolution, although it is said that it can accurately measure global ventricular function with excellent reproducibility. Echocardiography remains the preferred option for patients in this case. That's for patients. When one go through the option, we see the patients that usually the echo is preferred for patients with serial, that patients with left ventricular function in preference to this cardiac magnetic resonance imaging. However, it has also been used to validate non-invasive diagnosis of renal artery stenosis, and this is a screening choice for renal artery stenosis. So going back to the options now, say in which of the following clinical scenarios would an alternative imaging modality be preferred over magnetic resonance imaging? A. Diagnosis of iron overload cardiomyopathy in a pediatric patient with beta thalassemia major and congestive heart failure. So this is false. In this group of patients, the no alternative imaging modality is not preferred over magnetic resonance imaging because it's used in diagnosing patients with iron overload cardiomyopathy. B. Diagnosis of arrhythmogenic right ventricular cardiomyopathy in a 24-year-old man who recently survived a cardiac arrest. This option is wrong because it has a place in making diagnosis of arrhythmogenic right ventricular cardiomyopathy. C. Diagnosis of coarctation in a 17-year-old girl with hypertension and radiopulmonary delay or on physical examination is also used in patients with this condition. However, for option D, it can be used. However, an echo is preferred over magnetic resonance imaging, particularly in this patient described here, a patient, a 54-year-old woman with metastatic breast CA receiving anti-cancer chemotherapy. Then E, diagnosis of renal artery stenosis in a 78-year-old man with refractory hypertension. It has also found a place in patients with renal artery stenosis. So the correct option for this is option D, serial evaluation of left ventricular function in a 4-year-old woman with metastatic breast cancer receiving doxorubicin. So that's it for question 59. We'll move on to question 60. Question 60 is testing our knowledge on pre-test probability. Okay, the pre-test probability essentially indicates whether there is a strong likelihood or a disease based on clinical factors. So if a patient has a high pre-test probability, it means simply that if patient has the clinical symptoms and maybe physical examination reveals some um, findings suggestive of that particular disease, then the patient is said to have a high pre-test probability, particularly if with the clinical features that you've seen on from your history, then physical examination, then you do a diagnostic testing, the test comes out positive. So you say the patient has a high pre-test probability. However, if a patient there's a condition is said to have a low pre-test probability if your clinical features, if the clinical features doesn't really give a strong likelihood of the presence of the disease. And even though if you do a diagnostic testing after a procedure and find out that it's positive, that might be a false positive result. The intermediate pre-test probability falls between the high and low, and it often requires further investigations. Then pre-test probability influences the interpretation of results. He said that patients with positive a positive predictive value have a high pre-test probability. While patients with a negative predictive value have a low pre-test probability. Why post-test probability essentially, patient doesn't have those clinical features. However, when you do your diagnostic testing, you diagnostic testing is positive for the disease. So let's go back to the question now. They said question 60, figure 1.14. Figure 1.14. Okay, thank you. Figure 1.14 shows the post-test probability of coronary artery disease as a function of the pre-test probability of the coronary artery disease and results of exercise electrocardiography, showing either a positive stress test, which is indicated by the red bars, or a negative stress test, which is indicated by the blue bars. Then four different patient categories are mentioned in this graph. In answering the questions, I don't know if we can put them side by side so that I can give a little explanation. Okay. Dr. Izzy, please, can we go to the options? Okay, the first one here is option A says stress testing should be pursued in a 45-year-old man with atypical chest pain because if positive, the test will have the best positive predictive value of the cases shown. So we have to match these options with the graph that's shown. So can we go to the graph now? I'm trying to open it here so that I will explain from my side. Just give me some minutes. Few seconds, rather. Sorry, just in a few minutes I'll be there. Okay. Okay. Sorry. I'm just trying to open so that I can, while talking, I can be looking at the graph. I want to open it from my own end here. Almost there. Sorry.
Hello? Hello?
Yeah, I can hear you.
Um, it seems he has gone off, eh?
Hello?
Yeah, hello?
Yeah, can you hear me?
Yeah, we can hear
Okay,
you.
okay. So I'm there now. So looking at the options now. So if you look at this graph against the pre-test probability, like I said earlier, the pre-test probability tells you that a patient having clinical features, symptoms, then on from history, the physical examination, patient have the symptoms suggestive of a disease, then the patient is said to have a high pre-test probability, particularly when you do the diagnostic investigation and it's found to be positive. So you see that pre-test probability increases is on the x-axis, that's horizontal axis. It increases as you go to your left. For the first patient now, they said a stress testing should be pursued in a 45-year-old man with atypical chest pain because if positive, the test will have the best positive predictive value of the cases shown. So this patient described here, 35-year-old man with apical chest pain. That's the third one. That's the third plot here, the third bar on this graph. A 45-year-old man with apical chest pain. Looking at this, you see that the pretest probability for this patient is a little bit high. So they're asking whether the test will have a positive predictive value for this case compared to the other ones. Looking at this, you see that the third bar, that's the one with 55-year-old male with typical angina pain. Moving from 0 to 100 on the horizontal axis, now you see that the last bar, the patient with the 5-year-old man with typical chest pain has a higher pretest probability compared to this 45-year-old male with atypical chest pain. And I've mentioned earlier that the positive predictive value is higher. The higher the positive predictive value, the higher the pretest probability. So option A, saying that the stress testing should be pursued in 45-year-old man with apical chest pain because if positive, the test will have the positive predictive value of the best positive predictive value of all the cases is false because the test that we this 55-year-old man with apical chest pain has the highest pretest positive predictive value. Probably what I've said, because I've said that the higher the post, the pretest, pretest uh, um, the higher the pretest probability, the greater the positive predictive value, the better the positive predictive value. So a patient having 55-year-old man having typical chest pain, for this man, if you do having symptoms, by the time you do your diagnostic investigation, the man tests positive to the disease. Unlike this one that has a 45-year-old man with atypical chest pain. Looking at this, the man is even younger, does not have symptoms that are typical of probably, say, coronary artery disease in this case. So option A is false because the 55-year-old man with typical angina pain will have a better positive predictive value than the 45-year-old man with atypical chest pain. So option A is false. Then B, stress testing should be pursued in the 55-year-old man with typical chest pain because if negative, the test will have the best negative predictive value of the cases shown. Like I've said earlier, the negative predictive value increases with the higher the okay, the lower the pre-test probability, the higher the negative the better the negative predictive value. For this patient now, the pre-test probability for this patient is low. Okay, pre-test value for this patient is high. However, they are saying that the patient will have the best negative predictive value. The negative predictive value tells you about it has a correlation with the a low pretest probability. But in this case, this man has a high pretest probability, but his symptoms are being associated with a negative predictive value. So option B is also false. Then option C said the positive and negative predictive value cannot be determined for these patients from the given information. This option is wrong because we've seen that the positive and negative predictive value, the positive and negative predictive values have a relationship with the pretest probability. So it can give us information for the patients that we are talking about. So option C is wrong. Then D, a 45-year-old asymptomatic man without risk factors who has a positive stress test. That's this man, the first patient they're talking about there now is the first patient, that's the first bar on this graph, close to the zero on the horizontal axis. Say a 45-year-old asymptomatic man without risk factors has a positive stress test, who has a positive stress test is less likely to have a coronary artery disease than is a man of the same age with atypical chest pain and negative stress tests. This option is true because looking at this curve now, you see that the 45-year-old man, asymptomatic, no risk factor, has a low positive predictive value. It's because you can see this bar is closer to zero. The fact that the man has a low positive predictive value, so it's likely that the man will be less likely to have coronary artery disease than a man of the same age. That's this one now. That's the third bar here. Because looking at the third bar, this 45-year-old man with chest pain, looking at the bar, but the predictive value is above 40. So it has a higher predictive value. Since it has a higher predictive value, is likely to have the clinical symptoms are likely to correlate with the results I will get compared to a patient that has a low pretest probability. I don't know if we get it. It's somehow confusing. So I said earlier that the higher the pretest probability, the higher the pretest probability, the greater likelihood for that the patient has a disease. While the lower the pretest probability, the lesser the likelihood that the patient has a disease. So the 45-year-old man has a low pretest probability. So it's unlikely to have disease compared to a man with a high pretest probability of above 40. So that option D is correct. Then E, the pretest probability of coronary artery disease in a 45-year-old man depends solely on the presence of symptoms. It doesn't depend solely on presence of symptoms. No, we'll talk about clinical features, then maybe what you see on examination, then it's finally confirmed with a diagnostic test. So option E is false because the pretest probability of coronary artery disease in a 45-year-old man does not depend only on the symptoms. We have to also do some form of diagnostic testing to be sure whether a patient has that disease or not, even though the patient may have a high pretest probability. So that's the end of that's the last number that was given, question 56 to 60. Thank you. Hello?
Yeah, hello, we can hear you. Yeah, we can hear
Okay.
you.
So that's the last one for me.
Yes. I was just waiting for some seconds if someone had a contribution or question. Okay, so in the absence of that, kindly the next person, 61 to 65, Dr. Kenneth Inyedi.
Good evening, chiefs and colleagues. I'll be taking questions 61 to 65. Question 61 says, which of the following statements concerning imaging findings in hypertrophic cardiomyopathy is correct? The question is talking about imaging in hypertrophic cardiomyopathy. So the imaging would include transthoracic echocardiography, transesophageal echocardiography, cardiac magnetic resonance imaging. So the common one we usually do is a transthoracic echocardiography to make a diagnosis of hypertrophic cardiomyopathy. Patients would need to have left ventricular thickness that is more than 15 millimeters. Name any segment of the left ventricle. It doesn't have any specific location. And then, if the person in question has a family history of hypertrophic cardiomyopathy, as low as 13 millimeter can be suggestive of hypertrophic cardiomyopathy. So for a patient, the ESC said that for a patient that is hypertensive, if you're doing a ratio between the septal wall and the posterior wall, a ratio of more than 1.5 is suggestive of hypertrophic cardiomyopathy. But for non-hypertensive, a ratio of 1.3 is suggestive of hypertrophic cardiomyopathy. That's the thickness between the ratio between the septal wall thickness and the posterior wall thickness, in a way showing asymmetric septal hypertrophy. So other things we would find in echo in a patient with hypertrophic cardiomyopathy would be diastolic dysfunction. Remember that in hypertrophic cardiomyopathy, there is hypertrophy of the left ventricle. And then with this hypertrophy, most times the blood supply may be inefficient, and there may be some areas of fibrosis. So relaxation, it would be a problem. In this with impaired relaxation, the left ventricular end diastolic pressure would be high, and then with elevated left ventricular end diastolic pressure, the left ventricular filling will be impaired, and it would signify some form of diastolic dysfunction. Although generally it's thought that if you're looking at the gross systolic function, it could be normal, but if you're doing your strain and strain rate imaging, there may be some regional systolic dysfunction. Then the mitral valve apparatus might be abnormal. Most times, patients with hypertrophic cardiomyopathy would have elongated mitral valve apparatus, especially the anterior leaflets of the mitral valve. That's what most times contributes to left ventricular outflow tract obstruction when it slaps or hits the interventricular septum during ventricular contraction. And this systolic anterior wall motion also can contribute to mitral regurgitation that is found in hypertrophic cardiomyopathy. So apart from transthoracic echo, we can also do transesophageal echo. Transesophageal echo becomes important if you're thinking that the mitral regurgitation you're suspecting a primary mitral valve problem as a cause of the mitral regurgitation. So you want to assess the mitral valve closely. So you can do a transesophageal echo, or intraoperatively, if you want to check if you're successful in your surgical myectomy, you're assessing the left ventricular outflow tract, see if the obstruction is released, it has improved. You can do a transesophageal echo. Then for cardiac magnetic resonance imaging, it becomes important in patients that have poor echo window, or you want to assess, in hypertrophic cardiomyopathy, the hypertrophy is not just, it might not just be in the area that is easily assessed by transthoracic echo. There are some parts of the left ventricle that's not readily accessible using the transthoracic echo, like the apical apical part of the left ventricle or the left ventricular free wall. So you would want to do a cardiac magnetic resonance imaging. This will assess these parts that are not easily viewed with transthoracic echo. Aside from that, you can also, when you're doing your left gadolinium enhancement, you want to quantify the degree of fibrosis, considering the fact that if you have fibrosis of more than 15%, might be a risk factor for sudden cardiac death, and cumulatively might suggest if a patient will need an ICD to be placed. So with that as our background, we'll attempt the options. So option A says septal thickness is always abnormal in patients with hypertrophic cardiomyopathy. We are looking for the correct answer. So this option is false because you can have apical thickness, you can have thickness in any part of the left ventricular cavity. So it's not this, the thickness is not specific for the septum alone. So that makes that option false. Option B says diastolic notching of the aortic valve on M mode examination is typical in patients with outflow tract obstruction. Okay, so what happens is that during systole, not diastole, there's usually diastolic notching of the aortic valve as a result of this increased gradient in the left ventricular outflow tract. So that's if during the M mode, the box, the same kind of collapse at some part. So that's the diastolic notching. It occurs in that's the systolic notching. It occurs in systole, not diastole. Option C says the presence of systolic anterior motion of the mitral valve is consistent with dynamic outflow tract obstruction. This option is correct because for dynamic outflow tract obstruction to occur, there would be a presence of this systolic anterior motion of the mitral valve. That is what actually reduces as during systole, as it contracts, this anterior mitral leaflet almost occludes the left ventricular outflow tract, causing this left ventricular outflow tract obstruction. So option C is correct. Option D says myocardial relaxation velocities measured by tissue Doppler imaging are typically normal. So myocardial relaxation in hypertrophic cardiomyopathy is impaired because we need, because of the hypertrophy and then some form of replacement fibrosis. So relaxation is usually impaired in hypertrophic cardiomyopathy. There's no option E. Okay, question 62. Which of the following statements regarding cardiac hemodynamic is true? So the question generally is talking about jugular venous pressure waveform. We've heard it previously yesterday that we have 3 positive waves and 2 negative waves. The A wave representing atrial contraction and after atrial contraction, we expect the atrium to relax. So during atrial relaxation, the pressure falls, we have the X descent. During atrial relaxation coincides with ventricular contraction. During ventricular contraction, at the isovolumic contraction stage, there's buildup of pressure in the left ventricle that causes closure of the tricuspid valve. So that causes transient increase in pressure in the atrium and gives the C wave. So further atrial relaxation gives the and the suction and the tugging of the tricuspid valve downward gives the X prime. Then after the atrial relaxation comes ventricular filling. That's when there is increased venous return. So the pressure now increases because of the ventricular venous return into the atrium. Following this venous filling of the atrium, the next stage is atrial emptying. During atrial emptying, most of the blood is now transmitted through the valve, the atrioventricular valves, the ventricles, such that the pressure in the atrium reduces. So those accounts for the hemodynamic changes that occur as seen in nuclear venous pressure waveform. So we go to the options now. Option A says the Y descent of the right atrial pressure waveform represents relaxation of the atrium and downward tugging of the tricuspid annulus by right ventricular contraction. So the Y descent represents atrial emptying, not relaxation. So that makes that option false. We are looking for the true option. That's false. Option B says in the right atrium, in contrast to the left atrium, the V wave is more prominent than the A wave. So I searched the literature. One literature said they are the same, that the V wave in both the right atrium and the left atrium are the same. But the answer in Braunwald'S said this is the correct answer, that the V wave in the left atrium, it's more prominent than that in the right atrium. Option C says the Y descent is blunted in cardiac tamponade. Okay, remembering that Y descent occurs when there is atrial emptying into the ventricle. So in cardiac tamponade, it's said that there is a fixed volume of blood in the cardiac chambers. So during cardiac tamponade, during atrial emptying, since there is no space for blood to move from the atrium to the ventricle, there's usually no Y descent. So that's why descent is blunted. That makes this option true. That's why descent is blunted in cardiac tamponade. Whereas for cardiac tamponade, the X descent may still is usually present because during atrial relaxation, there is that coincides with ventricular contraction, and in ventricular contraction, some amount of blood leaves the heart chamber, like through the to either the lungs from the right side and to the systemic circulation from the left side. So there's some space for blood for the atrium to relax. So there's the pressure drops a bit. That's why there's wide X descent in cardiac tamponade, but there's no Y descent. Option D says tricuspid stenosis results in prominence of the Y descent. Tricuspid stenosis will cause more of a giant A wave because in tricuspid stenosis, the atrium have to contract a bit more to push blood against a narrow atrial and tricuspid valve that's obstructed from this stenosis. So that's forceful atrial contraction produces a prominent A wave, but not a prominent Y descent. So I don't know if there is any explanation for option B.
Sorry, please. Can you help with explanation for option C again, please? I had one of those. Thank you.
Okay, I said that in cardiac tamponade, that it said that the chambers have a fixed amount of the volume of blood in the cardiac chambers are fixed. They are not in cardiac tamponade. There's a pressure outside impeding expansion, relaxation of the chambers. So the amount of blood there is kind of fixed. It can't expand any further because of the pressure from the fluid outside. So what happens in Y descent? During Y descent, Y descent represents atrial emptying. So if there is a fixed quantity of blood in the cavities, in the chambers, there will be no flow from the atrium to the ventricle at any point because there's no space again for blood to move from this chamber to this other chamber. But during what happens in the X descent is that X descent represents atrial relaxation. During atrial relaxation is like atrial diastole, and that corresponds with ventricular contraction. During ventricular contraction, some amount of blood leaves the ventricle, either through the pulmonary artery to the lungs or through the aorta to the systemic circulation. So some amount of blood leaves. This gives some space for the ventricle for the atrium to relax more, and some fluid has left the cardiac chamber. So with this, as it relaxes, the atrium relaxes, the pressure drops, but it's not as significant as it is. There will still be some blunting, but it will not be as absent, almost absent as it is in Y descent. This is because of that some amount of blood that leaves the ventricle, giving it some more space for the atrium to relax more. I don't know if I've been able to explain better.
Please, are you okay with her explanation?
Thank you. Yes, I am.
Dr. Kenneth,
So
please.
question 63. Which of the following statements regarding the effects of maneuver on the auscultation of cardiac murmur is true? So it takes us back to the dynamic auscultation. Option A says, in patent ductus atherosus, The diastolic phase of the murmur is softened by isometric hand grip. So we expect a continuous murmur in patent ductus atherosus. Why? Because in both systole and diastole, the atrial pressure, the aortic pressure is usually higher than the pulmonary artery pressure. So in diastole, and this person is having, in the presence of isometric hand grip, we expect increase afterload. With increased afterload, the pressure in the aorta is enhanced. So blood is the flow across the ductus atherosus will be more. So we expect the murmur to be increased, not softened. So that option is false. Except when there is in the presence of pulmonary hypertension. So it said that when the patient develops pulmonary hypertension, so the pressure in the pulmonary artery might rise to some extent that either approaches or it's higher than the diastolic pressure of the aorta. At this point, they may be the murmur might be shorter or softer. But in the absence of pulmonary hypertension, and this person is undergoing isometric hand grip, we expect the murmur to be louder, not softer. Option B says the murmur of hypertrophic obstructive cardiomyopathy becomes softer with standing or during a valsalva strain maneuver. So during standing or valsalva maneuver, the venous return is reduced, the volume of the preload is reduced, the amount of blood in the left ventricle is reduced, making the left ventricular outflow tract narrow, and that will cause increase in the murmur of hypertrophic obstructive cardiomyopathy. So the murmur becomes louder, not softer. So the option B is false. Option C says the murmur of a ventricular septal defect decreases with isometric hand grip. Similar thing occurs when there is isometric hand grip. We expect increase afterload, and when there is increase afterload, the flow of blood will favor the chamber with the lower pressure. So there will be increased left to right shunts, and we expect that the murmur will increase, not decrease. Option D says isometric hand grip decreases the diastolic murmur of aortic regurgitation. The option D is false as well. So in aortic regurgitation, if there is increased afterload from the hand grip, this will favor more regurgitation because the afterload is increased, blood flows, regurgitation is more, flows backward more to the ventricle, increasing the flow across the aortic valve again. So we expect the murmur to be increased, not decreased. Option E says the diastolic murmur of mitral stenosis becomes louder with exercise. So with exercise, there is increased flow in the left side of the heart. So there'll be increased flow across the mitral valve. So we expect the murmur to be louder because of the increased flow across the mitral valve. So option E is the correct answer. Question 64. A 62-year-old previously healthy man is brought to the emergency department because of severe headache and dizziness. He has no chest pain or dyspnea. He takes no medication. His blood pressure is 186/98. His heart rate is 56 beats per minute and regular. The presenting ECG is shown in figure 1.15. Which of the following action is appropriate? Maybe we'll have to scroll down. Okay. So the ECG shows deep T wave inversion almost everywhere. Can see it from V1 to V6, lead 1, lead 2, lead AVF. It's more prominent there. So there are differentials for this kind of ECG in the right context. Maybe it can go for acute coronary syndrome, can go for Wellens type A, type B. Wellens type B because of this deep T wave inversion in the right clinical context. It can also go for apical hypertrophic cardiomyopathy. They usually have this very deep T wave in the lateral lead. Can also go for electrolyte abnormality. It can also be in this context, patients for Wellens syndrome, we expect that the patient will have history of chest pain. But they said the patient has no chest pain, no dyspnea. It seems like the patient has a clean cardiovascular system examination, except for the elevated blood pressure. And then patient has some central nervous system symptoms like headache and dizziness. So it looks like this is what we call cerebral T wave. Cerebral T wave occurs when a patient has severe central nervous system injury. So there is usually catecholamine burst, which will cause some repolarization abnormality ranging from this deep inverted T wave. There may be tachycardia, there may be bradycardia, and other forms of arrhythmia. So in this clinical context, it's more of a cerebral T wave than an acute coronary syndrome or electrolyte abnormality. So we go to the options now. Option A says initiate antiplatelet therapy with aspirin and clopidogrel. So it's not an acute coronary syndrome, so that makes that option false. Option B says initiate antithrombotic therapy with heparin. So this option is also false. Option C says initiate anti-ischemic therapy with intravenous nitroglycerin and a beta blocker. This option is also false. Option D says proceed directly to the cardiac catheterization if SC segment or T wave abnormalities fail to quickly normalize with anti-ischemic therapy. So it's important to make the diagnosis before commencing on this, because one of the differential for this cerebral T wave could be intracranial hemorrhage. So giving all these anticoagulants and might worsen intracranial bleed. That makes those options false, and there will be no need to go for a cardiac catheterization lab in this clinical context. Option E is the right option. It says obtain a head computed tomography scan. This will help us clinch the diagnosis of a CNS pathology, be it ischemic stroke, intracranial hemorrhage, or even traumatic brain injury. So we move to question 65. It says, which of the following statements
Sorry, before you move, Doc. Sorry.
Okay.
Good evening. I noticed Professor Ladimeji has his hands raised. So I don't know, Dr. Eugene, we should allow him to speak. Or let me just say something, pass a comment on this question you are asking, then we allow Prof to talk. I can see his hands are raised. Just was waiting, so you said if, yes, I agree with your differentials. That was excellent. But you said if it's Wellings that
Sorry,
the
stop.
patient will have chest pain. In clinical scenario for Wellings, it's possible that the patient has had chest pain, maybe prior days or prior to presentation. As at the time the patient is presenting to you, when you have this ECG, the patient might not have a chest pain, but there will be an history of chest pain in the patient. Do you get? So it's possible that the patient might be in front of you without a chest pain. And just like you have said, is a sign of imminent, like left atrial, left anterior descending obstruction. So pain will be there. You understand? The angina pain will be there, but you might not have the pain at presentation or when you have the ECG. Hope you got that. That's for when.
Yeah.
Then for other acute coronary syndrome, we know that we should also is a differential. Yes, I quite agree. But what would negate that is the patient does not have a classic presentation. One, then two, you have to have these ST segments or T wave changes in contiguous leads. Yes, it will really not be diffuse everywhere. For those that will be diffuse everywhere, where you have extensive, you still have ST segment depression in some other places, like when you have these excessive main stem, you can still have ST segment depression in AVR. You understand? There is a way that you will have the changes that will show that it's following an arterial territory. Do you get the point? So yes, I quite agree. But looking at the history, what fits it most, yes, is what you have mentioned. But for Wellings, there will be pain, but no pain application because they might create a clinical scenario for you that they might give you this thing, and the answer will be Wellings, but there will be pain. Thank you.
Thank you,
Professor Ladimi, sir.
Good evening.
Sorry, I think he has lowered. Okay, good evening, Chief.
Yes, ma'am. Good evening. Yes, and thank you for the opportunity to speak. Yeah, so I was trying to refer back to question number 62, where she actually asked for explanation of, I guess that would be option B. I guess you asked for an explanation there, right?
Yes, Chief.
Question 62, where the the option stated that in the right atrium, in contrast to the left atrium, the V wave is more prominent than the A wave. Okay.
Yes, sir.
So great. So when checking the AVP, we all know that the same waves we find for the right side, right atrium, can also are the same wave we see on the left, in the left atrium also. So that means that the same ACV wave, XY descent, both can be seen at the right and also in the left chambers as the right and left atrium. That's number one. So for The right atrium, it has lower pressure, right, than the left atrium.
Okay.
So that means that if we know what the V wave represents, that it represents a ventricular, it happens in ventricular contraction, right?
Yes, yes.
Also correspond to filling of the atrium at that
Atrium.
time. Great. So now the pressure in the left side is far higher than the pressure in the right side, right? So
Yes.
the pressure in the left atrium is higher than the pressure in the right atrium, and so the ventricles are likewise. The left atrium is less compliant because of higher pressure, have higher filling pressure than that of the right side. So because of the higher pressure in its chamber, its wave will be higher
Okay.
than that of the right atrium. And that V wave is far higher than A wave because of the same issue of non-compliance because of the pressure in the chamber. Unlike in the right side, the right atrial pressure can be as low as 3 to 5, we know, right? Compared to the left side, the left atrial pressure can be as high as 15 millimeter of mercury. So that brings to the point that in the right side, the pressure is lower, is more compliant, is a more compliant chamber than the left atrium. And so its wave would not be as high as the A wave. Remember that A wave represents atrial contraction, right?
Yes.
So that means with a contracted chamber, you expect high pressure. So the A wave in the right atrium is higher than the V wave simply because of contraction of the pressure generated from contraction in the right atrium. But for the left atrium, the V wave is higher because it has high filling pressure. If non-pathological state, it has a higher filling pressure than the right side. So that is why the V wave is higher than the A wave. Okay,
Thank you so much, sir. Yes, sir.
Thank you.
Thank you, sir. So we are at question 65. Which of the following statements about diastolic murmur is false? Option A says diastolic murmur are classified according to their time of onset as early diastolic, mid diastolic, or late diastolic. This is true. Diastolic murmur are classified as early diastolic, mid diastolic, or late, whereas systolic murmur has early diastolic, mid diastolic, early systolic, mid systolic, holosystolic, and late systolic murmurs. It's also important to note that most often, at times, diastolic murmurs are usually pathologic, whereas systolic murmur may not be pathologic, especially the innocent murmurs. So option B says, in aortic regurgitation, due to aortic root dilatation, the murmur typically radiates to the right sternal border. This is true. In aortic root dilatation, the murmur radiates. The typical murmur of aortic regurgitation is at the second intercostal space to the right, right? So, but in aortic root dilatation, it radiates to the right sternal border. Whereas if it is a problem of the valve, it radiates towards the left sternal border and to the apex. Option C says it is possible to differentiate the murmur of acute severe aortic regurgitation from that of chronic aortic regurgitation at the bedside. This is true. For acute severe aortic regurgitation, the murmur is usually shorter and softer. Shorter in the sense that the regurgitation is acute. There's no time for the left ventricle to adapt and probably become more compliant. So the diastolic pressure builds up rapidly and reverses the regurgitation. So the murmur is usually shorter and softer, whereas for chronic, the murmur is usually longer and louder. Then also for acute regurgitation, the intensity of the mitral components of S1 is usually reduced for acute aortic regurgitation, but for chronic, the intensity of S1 is unaffected. So we expect S1 to be reduced in acute aortic regurgitation. So reduced and S1, and then shorter murmur points more towards an acute aortic regurgitation, whereas a longer murmur, probably with a displaced apex and a normal S1, is more in keeping with chronic aortic regurgitation. Option D says, let diastolic, that's pre-systolic accentuation of the murmur, indicates that the patient is in atrial fibrillation. So this is talking about mitral stenosis, the murmur of mitral stenosis. So for pre-systolic accentuation, it will need atrial contraction to produce the pre-systolic accentuation. So in atrial fibrillation, there is no organized atrial contraction, so there will be no pre-systolic accentuation. So let's diastolic accentuation of the murmur indicates that the patient is in atrial fibrillation is false. That's the false option. Option E says, that becomes the answer. Option E says Graham-Still murmur begins in early diastole after a loud P2. That option is true. Graham-Still murmur is murmur of pulmonary regurgitation. It's an early diastolic murmur, and it usually begins with a loud P2, especially if it is due to pulmonary hypertension. That's the end of my allocated question.
Thank you very much. Please, any questions, contributions?
Yeah. Thank you, Dr. Eugene. Thanks to Dr. Sorry, what's your name now? I'm so sorry. Yes, thank you so much for taking your part and for your presentation. Just on this last part, please I can see pause down this up. I don't know if it's still the same hand or another one, but let me quickly make this comment so that we allow him to talk. I would encourage everyone to let's try and check up the hemodynamics of all what we see in all valvular heart diseases. If we can't check all, we should check MS, MR, AS, and AR. Even if we can't check tricuspid and pulmonary. So MS, MR, AS and AR, because they can ask MCQ questions twisted. It will surely come out. There's no way we can escape that. So concerning what you've explained, so that we don't cram and for understanding, the reason why the S1 will be short, what happens at S1? What gives the S1 heart sound
Sound.
S1? What gives it?
Closure of the atrioventricular valve.
Exactly. So closure. And when we have an acute AR, it's like blood is gushing back into a left ventricle, a normal size left ventricle. So there's no enough space. So as the blood is coming directly like that, it pushes, it slams the door. That's the mitral valve. It slams it. So it doesn't close like usual, like you hear your S1. So it slams it off. Do we get that? That's why the S1 is short, really. That's in acute AR. In chronic AR, I cite the fact that, after a while, when we have regurgitation, what we'll have in the hemodynamics later will be, and there will be an eccentric, there will be, let me say, left ventricular dilatation. So you see like an eccentric LVH. So when the LVIDD, when we have it dilated, there is enough space for the backflow of blood that is coming into the left ventricle. So it won't really slam, the door. That's the mitral valve. Now, yes, do you understand? So there will be enough space for the blood coming back, because it has happened over time and the left ventricle is now dilated. You have eccentric LVH. And for AS, on the other hand, what you see, the cavities will be normal size, will not be dilated, but there will be what? Hypertrophy. It will be concentric hypertrophy. So there are some things we should just try and put in our brains. Then for MS, for instance, now, in mitral stenosis, the left ventricle to assumes is normal size. It's like it's out of what you have, rather, it just be your left atrial dilatation. Unlike when you have mitral regurgitation, you have eccentric LVH as well as the dilated left atrium. I hope you are getting, hope I'm clear,
Yes.
hope I didn't confuse. Yes, so we should just try and read up all these hemodynamics, because questions can come in a lot of ways, just like this question you just answered now. So if you have that thing at the back of your mind, even if you've not seen the question before, it will be easy to logically reason out what the answers will be. Thank you.
Thank you, boss, for the contribution. We go to question 66. Dr. Ayodeji, please, are you on?
Sorry, please, can I quickly make this comment, sir?
Kindly go ahead, please.
Yes, I wonder how to re-explain option B in question 65. You made comments about this location of the murmur in aortic regurgitation. Can you just quickly re-emphasize it, please?
I can't hear you.
Am I audible? Am I audible?
Yes, I can hear now.
No, as in to readdress the murmurs of aortic regurgitation based on the location where you hear it. I guess you compared it with aortic stenosis, right? Am I audible, ma?
Please, you're audible.
Hello, Chief.
Yeah, I guess. Did you get my question, ma?
No, sir.
Okay, so we're trying to emphasize your explanation on option B about the murmur and the location where you hear aortic regurgitation murmur compared to aortic stenosis murmur.
Okay.
Can you just quickly re-explain, ma?
Okay, for aortic regurgitation, I was saying that the momo is located at the second intercostal space to the right second intercostal space for aortic regurgitation for valvular aortic regurgitation, and it radiates to the apex or to the left sternal border. Then for dilatation of the aortic roots, it radiates to the right sternal border.
Oh, okay. Okay. So I get you. So, okay, one important thing you should note is that, okay, let me just ask you, where is the aortic valve anatomically?
During auscultation.
And not where they tell us as anatomically. If you open the chest, where do you think the aortic valve will be?
It's oriented more to the left.
So that means it's close to the left sternal border.
Yes.
Okay. So the best position to pick aortic regurgitation momo, okay, is the Eppes point. I'm sure you know Eppes point.
Yes.
Okay, good. So that's the left intercostal space at the third left intercostal space to the left sternal border. Okay. So now that's the best point to pick AR momo, no matter how small the AR, as in even if it's mild, moderate, that's the best location to pick it. Now, if the person now has a dilated aortic root, okay, so that means that the momo can now radiate more to the right sternal border, okay, because the aortic root is now dilated, hovering over the right. Because if you remember how the arch forms, the ascending aorta comes from the left to the right and arches back to the left side. So when you have a ascending root dilatation, that ascending aorta expands all over the right, depending on how dilated it is, it expands all over to the more involving the right sternal border. Okay, so it simply means that when you're hearing the AR more for aortic root dilatation, you hear it more to the right side. It's important to note that one. But the best point to pick an AR momo is the Eppes point, the left sternal, or so left sternal border. Okay, thank you.
Thank you, sir.
Hello, thank you. Thank you. So we move on to 66. Dr. Edeji, please, are you on? Hello? Please, am I audible?
You are
Yes,
audible.
you're audible. You're
It
audible.
appears that Ayodiji can't hear you. I think she's muted. Is it Adedeji?
I have here Ibitoyi Ayodeji. Yeah. So it's Ayodeji.
It's not Adedeji, it's Ayodeji.
Ayodeji. Okay, sorry for that.
Okay. Do we have Abdulaziz on?
Yes, I'm on.
Dr. Abdulaziz, please, can you take your own for me? 71 to 75.
Okay. Good afternoon, senior colleagues and colleagues. I'll be taking my own session from 71 to 75. And for 71, read thus. Which of the following statements about digitalis-induced arrhythmia is correct. A. Atrial tachycardia with block is diagnosis of digitalis toxicity. B. Non-paroxysmal junctional tachycardia is highly suggestive of digitalis toxicity. C. The development of atrioventricular dissociation in a patient taking digitalis is a sign of digitalis therapy, but not an indication of digitalis toxicity. And D. Frequent ventricular premature beats are rarely a sign of digitalis toxicity. So first of all is that we want to consider digitalis, which are cardiac glycocytes. And as an overview, cardiac glycocytes are used clinically in two conditions, being used in heart failure due to systolic dysfunction and also being used in supraventricular tachycardia. And bear in mind that they have two properties. We have the inotropic property and we also have the Hello, am I audible? We also have the
audible
property. So as a result of that, it's possible that despite the fact that these drugs are being used, that they can also cause a life-threatening arrhythmia and due to their toxic manifestation. And we should bear in mind that it is have to be noted that the toxicity serum concentration that has been reported is when it rises above 2 nanogram per mil, which is equivalent to 2.6 millimole per liter. However, it has also been reported that toxicity below that particular value, which can also range between below 1.3 to 1.5 nanogram per mil, especially when patient is having other comorbidities like hypokalemia, hypomagnesemia, hypercalcemia, and even myocardial ischemia, as it's even possible for patients to exhibit digoxin toxicity, which has also been reported to induce arrhythmia. Now, going back to digoxin-induced arrhythmia, it should be noted that it can cause both bradyarrhythmia or tachyarrhythmia based on the mechanism which I've said before. You know that it has the inotropic property, increasing contractility, and this will be responsible for the tachyarrhythmia. Why the other one? Because of the negative chronotropic effect, it's possible to also give bradyarrhythmia. So all sorts of arrhythmia has been reported with digoxin toxicity. However, it has also been said that digoxin do not have direct, is not directly related, or digoxin do not directly induce some particular arrhythmia, such as atrial flutter, atrial fibrillation, or Morbus type 2 AV block. So meaning that if we should see this, is not a common finding. And the one that has been reported to be the commonest finding, digoxin-induced arrhythmia, has been said to be premature ventricular complexes. So going back to our question, looking at question A, atrial tachycardia with block is diagnostic of digitalis toxicity. This particular question is false because atrial tachycardia with block is not a diagnostic of digitalis toxicity. It has been proven that there are other causes of atrial tachycardia with block, not only limited to digitalis. Secondly, the second question is non-paroxysmal junctional tachycardia is highly suggestive of the digitalis toxicity. This has been said to be correct because though it doesn't mean that there are not other causes of non-paroxysmal junctional tachycardia. However, many a time when we have such, it is associated with AV dissociation. And once that is being seen, it is said to be highly suggestive of digitalis toxicity. Thirdly, the C question is the development of AV dissociation in a patient taking digitalis is a sign of digitalis therapy, but not an indication to digitalis toxicity. This question is false because this question is really talking about the ECG findings of patient taking digitalis. And that particular sign that has been reported with such like reverstic sign, cyclic sign, or orchistic sign, or the popular Salvador Dalí sign, is the one that has been shown to be in line with patient taking digitalis, but not an indication of digitalis toxicity. But however, this particular one is now putting the ECG findings to fit into this particular scenario. And lastly, is frequent ventricular premature beats are really a sign of digitalis toxicity. And as I said earlier, that the most common arrhythmia that has been reported in literature as regards to digitalis induced arrhythmia is premature ventricular beats. So that's all concerning this particular question. I don't know if we have any contribution or question as regard that before I move to 72. Am I audible?
Yeah, you are. So
Yeah, yeah,
I
I
missed
hear
it
you.
briefly. I stepped out. So what's the answer for 71?
The answer for 71 is B. B.
Oh, okay. All right.
Okay. For 72, this question with does. An 82-year-old man presents after a recent non-STEMI coronary angiography revealed severe three-vessel disease with 100% occlusion of the proximal left anterior descending coronary artery. In addition to that, we also have 100% mid-right coronary artery occlusion. And lastly, there was also 70% stenosis of the proximal left circumference coronary artery. Echocardiography demonstrated akinesis of the entire anterior wall, septum, mid, and apical anterolateral wall with an estimated left ventricular ejection fraction of 20%. Myocardial viability was evaluated using cardiac positron emission tomography with rest rubidium, which is being used as a flow tracer, while the F-label fluorodeoxyl glucose is being used as the metabolism tracer, as shown in figure 1.17 above. Which of the following statements is true? A, the images show a large region of PET perfusion metabolism mismatch in the mid-LAD distribution. B, this finding is consistent with the presence of scarred non-variable myocardium. C, radionuclide techniques are less sensitive than measurement of inotropic contractile reserve by dobutamine echocardiography for the detection of variable myocardium. And D, survival benefits associated with revascularization of hibernating myocardium has been demonstrated in randomized clinical trial. So looking at this particular question, summarily, you can see that it's an 82-year-old man with recent NSTEMI. And coronary angiogram that was done showed a multiple vessel disease with 100% occlusion of proximal LAD and mid RCA. However, with 70% proximal left circumference coronary artery stenosis, and echo has shown akinesis. So this particular session is testing on myocardial viability, which is being evaluated using cardiac position emission tomography with rest rubidium 82 for flow tracer, and also using F-label fluorodeoxyglucose as metabolic tracer. So let me quickly give an overview concerning PET. Is an established non-invasive method of evaluating myocardial perfusion and viability. And it can assess both perfusion and metabolism. And the mechanism through which this particular in place is that the ischemic shift myocyte metabolism, preferentially to glucose from fatty acid. Uptake of glucose analog, which is the fluorine 18 labeled FDG, by myocytes in an area of dysfunctional myocardium. This indicates metabolic activity and lead to viability. So regional perfusion can also be assessed with an agent that remain in the vascular space and demonstrates distribution of blood flow, as was demonstrated in this particular scenario, whereby rubidium is being used. But an alternate to rubidium is also nitrogen ammonia. So PET can differentiate between normal myocardium, stonic myocardium, hibernating myocardium, or necrotic myocardium. Now, for hibernating myocardium, this is when we have the presence of enhanced FDG uptake in the region of decreased blood flow. And this is being called PET mismatch. In this case, we are having uptake of the oxyglucose in a particular part, in a particular region, which does not match with blood flow, because at that particular region, there is decreased blood flow. This is regarded as PET mismatch, and it is known as hibernating myocardium. The other one that I would like to talk about is the stoning, whereby there's also regional dysfunction in the presence of a normal perfusion. In this case, this is being referred to as stoning. While the last one, which is the necrotic myocardium, which is being used as carrying here, is when we are having concordant reduction in both metabolism and flow. And this is being regarded as PET match. So going back to our figure, when we look at the first two parts, the upper part, we can see that the upper one is at rest. This is a short axis view where the first row is showing the rest part, while the lower one is the one that the radioisotope is being injected to match what is really happening at the upper part. So when we look at the first one, based on the scenario that was being given to us, we know that we have 100% occlusion of large, 100% occlusion of right coronary artery, and we also have 70% occlusion of the left circumference. So looking at it, we have to also match the coronary supply of that particular arteries to the region where we'll be matching. So this first one, the rest one, looking at it here, we have the anterior, septal, lateral, and inferior. And if we should look at it well also, realize that the left circumference, which is the one that is 70% stenosis, will definitely supply the lateral part of the left ventricle. Now, the first one, going through it, you look at that there is no uptake or there is no flow, there is no, yes, the rubidium, it shows that there is no flow of that particular isotope throughout the rest part. Although by getting to the end, the last part, the last two, it's showing that it is coming up gradually, and it's the lateral part that is coming up compared to the septal, the anterior, and the inferior. But by the time we match it with when the FDG is being given, we realize that there is uptake of this particular metabolism tracer as compared to the uptake when we are considering the flow tracer. Moving laterally to looking at the same region, we can see that even the septal, the anterior, and the lateral part have been they are uptake of the FDG. And as you are moving laterally, it looks more pronounced. So, and as a result of that, matching each of them, the upper and the lower one, we can see that there's evidence of PET mismatch in this particular part. And this is telling us that it is possible that there may be flow in a particular region, or there may be obstruction or no flow in a particular region, and that does not connote that that region is not viable. Because looking at it, we realize that despite the fact that there is obstruction in those areas we mentioned, it is still metabolically active based on the uptake of the FDG, and it is also viable. So coming down to hello, am I audible?
Yes. Do you want me to move it to a particular place for you?
Yes, I'm also checking. Yes. So I now want to consider the second part, the second two, which is another axis. The first axis that I first looked at, I think that one is the short. That one is the short axis. So the second part now is I can't see it well. Okay. So the second part, which yeah.
Is it
so
better?
The second part, yes, I can see it now. So looking at this second part that is also showing the vertical axis, we have to also match the rest with the FDG on. So looking at it, we can also see evidence of mismatch from different aspects of the myocardium. When we look at the anterior, match the anterior at rest with the anterior when FDG is being given. And we also match the lateral here at rest with that of the lateral when FDG is being injected. Will also agree with me by going through all that particular row, matching it with the corresponding FDG. There are also a lot of mismatches in this particular one. So I think let's just go to the question, because the same thing is still applicable to the last part of it. So the question now reads, the images shows a large region of PET perfusion metabolism mismatch in the mid-large distribution. I think from what I've been said earlier, we all agree that this is supposed to be true. But let's still look, since it's one of the best answer, we need to look at other options. B, the finding is consistent with the presence of scarred, non-viable myocardium. This is false, because I've said it based on the nephrotic. When I define nephrotic myocardium, this is the one that you have matched PET. But the one that we are considering is mismatched PET. So this definitely will be wrong. For C, radionuclide techniques are less sensitive than measurement of inotropic contractile reserve by dobutamine echocardiography for the detection of viable myocardium. yes, this is just pointing out that we have other modalities through which we can test for myocardial viability, apart from the nuclear imaging and nuclear radioactive substance that we use. And this include dobutamine echocardiography. We also have the cardiovascular magnetic resonance, and there's one that is under investigation now, which is myocardial contrast echocardiography. But since we are comparing the the dobutamine echocardiography with that of the radionuclide technique, it is being said that dobutamine echocardiography is more specific and less sensitive compared to radionuclide. So this is now being turned the other way around, that now we expect that the dobutamine echo is more specific and less sensitive, meaning that the radionuclide must be more sensitive and less specific. And the question said radionuclide techniques are less sensitive. So that particular one, less sensitive, make it to be wrong. So going to the last part, which is option D, survival benefit associated with revascularization of hibernating myocardium has been demonstrated in randomized clinical trials. Looking at this question, I almost accepted it, because it's just like a statement of fact that survival benefit associated with vascularization of hibernating myocardium will definitely have will support survival benefits. But what makes this question to be wrong is in randomized clinical trials, because it is not in randomized clinical trials, it is a observational study. And this has shown that ischemic cardiomyopathy and large areas of viable myocardium identified by non-invasive cardiac imaging have superior rates of survival, and it has been also more substantial improvements in left ventricular function, also have greater reduction in symptoms of heart failure and better exercise tolerance after revascularization than patients with large non-viable myocardium. So what makes it to be wrong is just that the randomized clinical trial. So of all this, 72 answer is A. So I don't know if we have any contribution or question as regards to that before I move on to 73.
Thank you. So with respect to the option D, the trials, so the STITCH trial looked at the coronary revascularization by CABG, whereas the REVIVE looked at PCI. So if you look at the STITCH trial, yes, there was no mortality benefit, but after 10 years, there's the suspicion that long-term, the functional capacity of those who had the CABG was better and may impact survival. But the revival that was done, so we can also look at revival, that is for PCI in patients with ischemic cardiomyopathy with EF less than 35%, for which they assess viability with different methods. That was randomized. That one to show no benefits. So generally, it appears that yes, if we have ischemic cardiomyopathy with reduced EF, there's no much benefit with revascularization. However, based on the STITCH trial, there is the suspicion that after 10 years or after long-term follow-up, the patients from the REVIVE trial may show benefit. So depending on how the discussion goes, there's the trend of suspicion of long-term benefits compared to the acute mortality and survival benefits. Thank you.
Thank you. Can I move to 73?
Dr. Ola, let me get the name correctly. I just saw a hand raised. Oh, it's gone. Okay, hand was raised. Ola Dimeji.
Yeah, sure. So thanks for this opportunity. I just want to ask the platform, do we now understand how to read radionuclear imaging in case they post it in the exam, especially in the OSCE station? Is it clear to us if we see these images and they post it in OSCE station, will we be able to be comfortable answering the questions or describing the images? Just want to be sure the platform is comfortable with the images. That's all.
Yeah, Prof. So for me, I think a reinforcement would be good, but I must admit the discussions have made things clearer with respect to me. I don't know about my colleagues, but I think a reinforcement by someone with expertise in that area will also help.
Okay. So can we go to the images now? If you can scroll to the figure. Yeah. Okay. Thank you. So one important thing we should note that, we talked about PETs and SPECT the last time. We tried to differentiate the advantages of one over the other. So we said PET scan is more sensitive, more specific than SPECT. One important thing about PET, as in PET, can also give you the coronary blood flow. You can quantify the blood flow through each of the coronary arteries based on the layer they supplied. Compared, unlike in SPECT, you will not be able to do that. In PET, it's more tedious to do and more expensive. So that's the disadvantage. Because the radionuclide agent you choose, it's very difficult, more labor intensive to generate that radionuclide imaging. So rubidium, ammonium, to generate it before you now give the patient as an agent is a very tasking, demanding process. Now, so that makes the procedure much more expensive. Now, for SPECT is cheaper. Two is that it can easily be done. And even when you give the radionuclide imaging, it stays far longer. You can have a SPECT test that the patient can come 40, even up to 72 hours after giving the agent to still check for the uptake. So that means that's how longer it takes. It lasts longer in the blood system. Number three is that it has a lot of false positive to it. So that's why they will say nuclear imaging is more sensitive but less specific, because it carries a lot of false positives. So we talked about those attenuation impacts, breast infarct, lung infarct, and a lot of artifacts. So all those artifacts would cause a lot of false positive and affect the interpretation of the results. But that is the advantage of now the PET over the SPECT. Okay, so one important thing you are looking at for, as we previously said, is that when you are assessing the images, you are trying to look at the myocardium and you are looking at the chamber. So myocardium and chamber. What are we looking at for in the myocardium? You are looking at uptake of the radioisotopic agents by the myocardium. Now, if the radioisotopic agent is not taken up, it won't appear on the slides, on the images, and that's trying to emphasize the fact that there is reduced flow or no blood flow to that vascular territory. So when we look at the uptake, you are looking at the myocardium, and you are looking at, if you are indirectly interpreting the vascular territory when you look at the myocardium. Okay? So that is why they will give you the different segments of the myocardium with its accompanying vascular territory. So that is what is actually shown on the images based on whatever they label for you. Okay, so if you are saying anterior, lateral, septal, inferior wall, it is telling you the different vascular territories. So you are looking at the perfusion of those territories to know which of the vessels are affected. Now, there are two ways to assessing or the protocol for this test. There are two ways to this protocol. One is you can do a pharmacological stress test or non-pharmacological stress test for for nuclear imaging. And you can also do metabolic activity tests for radionuclide imaging. So what we're trying to say in essence is that if you want to do a stress PET or stress SPECT, you can actually do it by giving a pharmaceutical agent which we mentioned before, adenosine, regadenosin, or dipyridamole. That is going to stress the myocardium, right? And you are checking for perfusion defects, stress. Or you can choose another protocol, which is to give a metabolic agent, which should be taken up and utilized by that tissue. So, like this one we are looking at, for instance, you are looking out for metabolic activity of the myocardium. And that would also help you interpret viability. Okay, so if we take this, for instance, now, you have images at rest. That means before, and remember this is metabolic activity, and this is also images after giving metabolic agents that can be utilized by the tissue. Okay, so if you look at and every time you're interpreting both at rest and at stress, or at rest and at when metabolic agents is given. So you have to interpret, compare. So you are taking the cuts of the myocardium both at the rest and when the metabolic activity agents are given for different segments of the heart. So you have to compare them. So for example, now if you look at this slide now, you see the top two rules. One is for rest, the other is for when the metabolic agent has been given. So you can see that when it's at rest, you are not seeing the perfusion. Can you use your pointer or your arrow? So you are looking at this is the short axis view now. So you can look at you can see that at rest. Yes, so for that first panel now, you can see that at rest, if you take one, let's take one segment, one box. Now you can see that the color it shows. Well, if we use this color now, sorry, I don't know.
Purple.
But it looks very maybe violet color or something, or purple or light purple. You get what I mean?
Purple.
Dr. Eugene, you can help me circle one of the myocardium. Yeah, so let's circle that myocardium. Yes. So you can see the way you have circled the myocardium for us. Okay, good. So you can see that its perfusion is very limited. Okay, compared to when given the FDG below. So you can see, so you can go to the one below it now, directly below it. You can take your marker. Yes, so you can circle. Yes, so you can see the perfusion of the myocardium very well in this. So that simply tells us that at rest, there is reduced perfusion. So that tells you that, oh, there's some form of reduction in vascular flow, right? But when we give a pressor agent that is metabolically active, it's the tissue that we think is not perfused is using that agent is using up the glucose. So that means that the tissue is not yet dead, it's still viable. So you can see how we check for viability here. So we are testing for viability when we are using metabolic agent here, just to show that even though there is reduced perfusion, the tissue is still utilizing glucose, FDG glucose. That means the tissue is still alive. Is this clear? I need to be sure this is clear.
Yes, clear.
Yes, sir.
Okay.
Yes, sir.
Yeah, good. So that tells you that if this patient has opportunity for revascularization, this patient should be revascularized so that when that tissue gets sufficient blood flow, probably the tissue can now be more active, right? So that tells us that there is positive viability test here. It's positive. So this patient will get opportunity for revascularization. Okay, so this is when you use FDG glucose for activity. Okay, I think there will be another slide for that of stress. So when we get to that one, I can use that of stress also to explain. Now, one other important thing we mentioned when we are looking at this slides also is to look at the cavity. Okay, no, before I go to cavity, don't forget that as you continue to look at this, the other slides, you will also check for vascular territories. So, for example, if you go to the third panel now, Dr. Eugene, let us isolate the third panel. Yes, so the third panel, so which is the third row. From the annotated area, you can see from the first box, the annotated apex, anterior, lateral, inferior, and septal. So if you look at the lateral, and the septal wall, so anterior, lateral, and septal wall, you will find out that and the septal also, you can see that there's reduced perfusion, right? So that tells you that compared to the inferior wall is better perfused than the septal and anterior lateral, right? So that tells you that there's a vascular territory. They are telling you that that's a problem. So that vascular territory has a problem, and is the LAD axis, okay? LAD and some part of the circumflex because of the lateral wall, okay? Now, so that tells you that, but if you look at the FDG afterward, the FDG, which is the fourth row, shows that even those areas had good uptake, right, of the FDG. So that tells us that they are still viable, but it has given you the anatomical location that it is the LED axis. So that, and if you go to the fifth panel, so the fifth panel now, you can see they've also annotated for us apex, lateral, septal, and the base. You can see that there is reduced perfusion of the apex, right? At rest. So still telling you that that is LAD territory, more of LAD territory. So that tells you that. So you put all this information together to finalize the vascular territory that is affected. It could be single vessel, it could be multi-vessel, but you look at all the information you have to make up your mind. Okay? So we can be rest assured now that the apex is involved, which is LED axis is involved. But even though it is the reduced perfusion, it's still viable because it can use glucose. If it was infected, it won't use the glucose. So that means that FDG, it will also be what? Reduce uptake if it is not a viable tissue. So I want to be sure this is clear.
Yes, sir.
Very clear, sir.
Okay, thank you. So I'll hand over, we can move on.
Okay, thank you, sir.
Sorry,
Question.
excuse me, sir. Excuse me, sir.
Yes, madam.
Okay, thank you very much, sir, for this clarification.
For the rest, for the images for the rest, so that would mean angiography. The flow we get on angiography or that's at rest before use of the radionuclear agents. So I don't know if I'm clear, sir.
No, I didn't get that. You said at rest angiography. I didn't get that.
Oh, sorry. Yes, what I mean is that those images obtained at rest.
Mm-hmm.
What exactly do you mean? Is it when angiography were done, or at what exactly was done at rest? Is it just based on angiography reports, or what, sir?
Okay, I get your question. Okay, so I'll describe everything to you. So the first thing you do when you're assessing a patient for ischemic heart disease, you will have done your ECG, your echo, you see a reduction in EF, you are suspecting maybe global hypokinesia or regional hypokinesia, I'm not sure. So you likely think the patient has what? Ischemic heart disease. So the next thing you want to do is to send for, based on your risk stratification, you can decide, oh, maybe the patient should go and do a CT coronary or go for invasive coronary, right?
Yes, sir.
So they go for invasive coronary, like this patient now went for invasive coronary angiogram, and they saw that LED was occluded, right? And they said some part of the circumflex. I guess that's the question.
Yes.
The question that attached to this patient. If you can scroll up, Dr. Eugene, if you can scroll the slide up, we can read the question.
Yes, LED is 100% occluded, RCA 100% occluded, then left circumference is 70% occluded.
Can you see that, man? That this patient has gone for invasive angiogram, right? And LED is occluded, RC is occluded, circumflex occluded. Now, you can, so with this kind of information, you want to tell yourself, should you revascularize or not? Because this is chronic ischemia now, right? It's not acute MI. This is chronic because the patient has, well, for you to have 100% multi-vessel disease, it's not likely to be acute. All the vessels cannot close at the same time. Okay? So that means that he had some chronic ischemic events. So you can now have another acute insult, which is the end-stemming she had. But then we all know that when somebody has ACS, LAD, circumflex, RC can all be all occluded at the same time. So most likely, some period ago, she will have had occlusion of LAD. Then later, it involved circumflex. Then later, maybe RCA now got involved and she now went into acute coronary syndrome. You get? So the question you now want to ask yourself as the interventionist or as the cardiologist is that should we revascularize this patient or not? Should we send for CABG or not? If the area supplied is infected, revascularization, right? If it's a transmural infarct, if you revascularize, it's dead, right? Are you getting me, man?
Sir, yes, sir.
So for you to decide to revascularize or not, you cannot send the patient now for nuclear imaging stress test. So, or any other stress test. You can send them for stress echo, stress cardiac MRI, or nuclear imaging stress test. What are we doing there? You want to test if those tissues are still viable. That cannot be determined angiogram. Viability cannot be determined when you are doing angiogram. Either it is CT or invasive angiogram. Are you getting me, man?
Yes, sir.
So that is when you now bring them for viability testing. So if the viability testing you choose is nuclear imaging, so the person goes to the radiology department, they now do that imaging protocol for them. So when we use the word rest, that means that the patient is in the machine, okay, at rest, and they are now they would inject the radioisotope, okay. So the isotope which is for PET now they use rubidium or ammonia. For SPECT they use technetium or thallium. Okay, that there is no any physical activity to the patient, so the patient is at rest, sleeping on the table, and you inject the radioisotope agent. Then you will now use your gamma camera. It's a camera that will take the image. So those images are the images we are now seeing in the figure. So you can go to the figure, Dr. Eugene. Dr. Eugene? Okay, you can go to the figure. So the first panel or the first row, which is at rest, the third row is at rest, the fifth row is at rest. That means that the patient is lying on the table, not doing any activity, and you inject the radioisotope agent. Okay, and that camera will now pick the flow through the myocardium. Do you get that, man?
Yes, sir.
Good. So that's taking out the cut. The same way you take images when you are doing stress echo. The patient will first lie down, Abi. Before the stress, you take all your images, epical for epical to short axis, Abi. You take all your images, right?
Yes, sir.
The next thing you do after you've taken all those images is to now determine if you want to do metabolic activity of the tissue. You can now give a metabolic agent that can be used in the tissue, which is glucose. Okay?
Yes, sir.
Do you get that, man? So,
yes, sir.
If you now give the glucose, you will now also now take images again of the same axis you've taken when at rest, so that you can compare the regional segments of the myocardium. Do you get that, man? So just the same way you will do a stress echo, first take all your images at rest, then you now go and stress the patient. Either you want to do exercise stress or you want to do pharmacological stress, Abi? Then you now take images of that same axis that you have taken at rest, so that you can compare, is there regional wall motion abnormality differences, both at rest and at stress, or both at rest and when giving FDG. Do you get that, man?
Yes, sir.
We also say there's also what is called stress PET or stress SPECT, meaning that at rest, you gave your radioisotope agent. The patient is at rest. You took all your images. Then you now go and stress the patient. You will tell them to go and do either Bruce protocol, and they come back. When you think the myocardium is stressed, then you take the images, or you give pharmacological stress agents like you said, adenosine, eugadenosin, diphenhydramine. You give those agents. You now check. Then you now bring them back to take the images at stress. Do you get that one? Is it clear?
Thank you.
So it is now get, if the tissue is now viable, then you can now send back for revascularization, either by percutaneous or by CABG, because you now are sure that the tissue are viable for revascularization. So does that answer your question?
Very well, sir. Thank you very much, sir. I appreciate this so much.
Thank you very much, Prof. Yeah, so kindly complete your sessions for us. Then we call it a day. Our time is already exceeded. But if colleagues will indulge me, let's complete your questions, then we move on. Then we can close. So we are done with the 72. Okay. So you can do the 73.
I need to be fast about it. So 73, which of the following statements regarding physical findings that distinguish the manner of aortic stenosis from the manner of hypertrophic cardiomyopathy is true? A, the strain pace of the Valsalva maneuver decreases in the intensity of the murmur of both AS and HCM. B, the carotid upstroke in HCM is brisker than in AS. C, the murmurs of AS and HCM both radiate to the carotid artery. D, if a systolic trill is present, it is most often located in the second right intercostal space in HCM and at the apex in AS. And E, squatting increases the intensity of murmur of HCS. So first thing we need to know is that both AS and HCM they cause harsh systolic murmur. And also there are physiological maneuvers that enhances contractility, increases the intensity of both murmur. However, there are some subtle differences between AS and HCM. So looking at the question here, the strain phase of the Valsalva maneuver decreases the intensity of murmur of both AS and HCM. This is not correct because the maneuvers that reduces left ventricular filling, such as strain phase of Valsalva maneuver or standing from a squatting position, decreases the intensity of AS murmur. But in HCM, the decreased intraventricular volume causes left ventricular dynamic outflow obstruction to intensify, and the murmur of the HCM becomes louder. So it's reversed, as been said here. Secondly, is that the murmur of HCM diminish in intensity with maneuver that augments left ventricular filling, such as sudden squatting or squatting from the standing position. Looking at the question B, the carotid upstroke in HCM is brisker than in AS. Carotid upstroke is reduced in amplitude and also delayed where we have the pulsus pavus ectados, as has been explained by my colleague earlier, and this is seen in AS. But in HCM, it initially brisk, then diminishes in mid-systole at the left ventricular outflow gradient increases. So looking at this particular question, that means we expect that of HCM to be brisker than that of the one that is being seen in AS. And this makes question 73B to be the correct answer. Though we are yet to go through the other one. Let's see if there's another one that can be the best compared to B. The murmur of AS and HCM both relate to the carotid artery. This is also wrong because it is that of the AS that relates to carotid artery, not HCM. D, if a systolic trill is present, it is most often located in the second right intercostal space in HCM and at the apex in AS. This is also wrong because in AS, the trill is located at the second right intercostal space, while that of the HCM is at the fourth left intercostal space, not the apex as been said here. And lastly, squatting increases the intensity of the murmur of HCM. This has been said earlier that it doesn't increase the intensity. So the correct answer here is that the carotid upstroke in HCM is brisker than that of the AS. Any contribution, question, or I should move to 74?
Let's move to 74. I think it's clear.
All right. So which of the following statement is correct regarding the oral anticoagulants, dabigatran, rivaroxaban, and apixaban in the treatment with AFib? So the options are the agents. These agents are as effective as warfarin for prevention of thromboemboli in patients with AFib and mechanical valves. So first considering this particular statement option, they are as effective as warfarin in prevention in patients with atrial fib and mechanical valve. So they are not good for mechanical valve when treating AFib. It is warfarin that has been said to be the best anticoagulant to be used when we are dealing with mechanical valve. However, the recent ESC guideline 2024, apart from using warfarin for mechanical valve, the other exception that was also being used for valvular valve is mitral stenosis, making it open that other valvular heart disease, we can still use the direct oral anticoagulants. It's only singled out mitral stenosis as part of the valvular heart disease that drugs should not be used with. But it is clearly stated that for mechanical heart valves, warfarin is the only answer. B, so that particular A is false. For B, each of these drugs can be used safely in patients with advanced renal disease. This is also false, as we know that there are some of them, like the rivaroxaban, the dabigatran, that they have to be renal dosed. Once we have EGF of less than 50 or less than 15, rivaroxaban is highly contraindicated. So it is not applicable. But for apixaban, we can use it because it is not, I think it's not metabolized by the kidney. I think it's more of the liver. So we use the same dose irrespective of what the EFR or the creatinine clearance is. For C, intravenous idarosibumab rapidly reverses the anticoagulant effect of dabigatran. This is actually correct because it is the antidote for dabigatran. However, I think it's not readily available as it has been said, but it's still the correct answer to dabigatran. While rivaroxaban and the apixaban, I think is andazonate alpha that is the antidote to those ones. For D, so C is correct for now until let's look at D. For patients whose international normalized ratio levels on warfarin are varied due to non-compliance, rivaroxaban is an excellent alternative given its once daily dose. This is also not correct because rivaroxaban, its half-life is said to be around 9 hours. And the effects of the anticoagulant generally on drugs expires after the maximum is after 24 hours. So for a patient that is not compliant, it won't be appropriate to place them on this particular group of medication because if they are placed on it and patient is not compliant, the complication that will come from it is very high. So from all these options, I think option C is the correct best answer out of all the 4 options. Any question, contributions, or we should go to 75?
Just to quickly state that there is renal adjustment dose for apixaban also in advanced CKD. Thank you.
I didn't get that.
There's renal adjustment dosage for apixaban in advanced CKD and in the elderly.
Okay, all right, noted. Thank you. So 75, a 73-year-old woman with exertional angina is referred for a standard boost protocol exercise tolerance test with thallium-201 single protein emission CT. Our nuclear images are shown below. What is likely diagnosis? A, dilated cardiomyopathy. 2, single vessel coronary artery disease involving left circumflex artery. C, prior inferior myocardial infarction with high-grade stenosis of the right coronary artery. D, left main or severe multivessel coronary artery disease. And E, normal coronary arteries. The images demonstrate West attenuation infarct. So going back again, based on what Prof had just said, that you can still see the similitude of using stress to look at the perfusion and the cavity of this particular myocardium of this particular patient. So this first one is showing short axis from the apex to the base. And the first two columns, the upper one is the stress, while the lower one, first two, is at rest. So by the time we move, and we get to the 1, 2, 3, 4, 5, 6, 6 box, so that we start appreciating it's 6 or the 8, 7 to 8 box, because we didn't see anything for about 4, 5, 6, 7 boxes before we start appreciating it at the second to the last and the last boxes. So when we compare this, we realize that the at rest, when you look at the cavity at rest is, the cavity at stress looks larger than that of at rest, right? So when we go to the third and the fourth column 2, we also observe, following it like that, comparing the stress and at rest 2, we realize that the uptake is more pronounced at, no, the cavity. I think we are considering cavity more here. The cavity is larger at stress compared to at rest. Coming down to the horizontal long axis, moving from inferior to lateral. At stress also, the cavity moving laterally, realize that is larger, more dilated than when compared to at rest. So the same thing is applicable to the vertical long axis. The cavity there also is larger, more dilated at stress than also at rest. I think we are able to follow me the way I'm saying it. Now, the issue now is that when cavity is larger at rest and when cavity is larger at stress, but remain normal at rest, this means that the blood supply or the perfusion to the myocardium at that particular area is occluded or not well perfused, and making a regional dyskinesia, or what I can call this a enlargement of the cavity at that particular place. Now, in this particular instance, looking at the option A, which is said to be in tandem with dilated cardiomyopathy. For dilated cardiomyopathy, we expect that this is supposed to even be dilated both at rest and at stress, with stress. So not that it is exercise that will induce that constriction or obstruction that will now make that particular cavity to be dilated, or the left ventricular cavity to be dilated. Ordinarily, without stress, it will also be dilated, and when it is even being stressed, I don't think there will be any significant difference in terms of the dilation. Now, for the second option, which is a single vessel single vessel coronary artery involving the left circumference artery. So for this to involve the left circumference artery, you know that this will affect more of the lateral part of the myocardium. And in that case, we're supposed to have an isolated perfusion defect at the lateral or the posterior wall when stressed. But this is not the case that we see here. Looking at this is not limited to the lateral parts. We can also see this dilatation or the increase in cavity in the inferior and the anterior parts of this particular diagram. But in addition to that, we can see that also in septal to that of the lateral part. So what I'm saying in essence is not that it's not a fixed or limited to just the lateral as being said in this left circumference artery that will be manifesting. And the third one, which is prior inferior MI with high-grade stenosis in the right coronary artery. So for right coronary artery, we expect this to supply the inferior wall. And the same reason is still applicable to what was being explained in the previous one, because this dilatation or increase in that cavity at rest, with stress or with exercise, is not limited to the inferior wall. It also extends to the anterior, likewise the septal and the lateral. So D is the left main or severe multivessel coronary artery disease. This looks to be the right answer because when left main is affected, it's the one that will later branch, which will have the LAD and also the left circumference. And also when we say severe multivessel, it's possible to also involve the right coronary artery, which is what is being seen here because it cuts across all the segments, which may make this to be the right answer. But we still need to go to the last part, which is the normal coronary arteries. The images demonstrate breast attenuation artifact. It's clear that it is not normal, because if it is normal, we won't have dilatation with stress for the cavity to be dilated as compared to what occurred at rest. And it is also being expected that when we have breast attenuation, there is also fixed defect at the anterior wall. But as it was being said before, that is not only the anterior wall that is being affected, it affects almost every part of the segment. And this will make the left main and or the multivessel disease to be the right answer. So I think that's all for now. If there's any contribution, I will really appreciate it. Thank you.
Thank you very much. Thank you very much. Very well explained. I don't know whether Prof still wants to add a comment, especially with respect to the nuclear perfusion studies. In the absence of that, I think we've exceeded our time, and I'm grateful for your patience. I wanted us to at least exhaust the minimum 20 we agreed on. So God willing, tomorrow we'll continue. We have some individuals who have missed their sessions, but they promised to cover it up tomorrow, 36 to 40. And also the other session we missed today, I hope that our colleague will do that tomorrow. God willing, we'll meet tomorrow. If the consultants and seniors on the page have any word to add, they can add. And otherwise, we'll meet tomorrow the same time, 8 p.m.
Just before we go, Dr. Eugene, the people that miss their parts, did they call you to notify you that they will not be around?
Yes. So the one doing the 36 to 40 notified me. The one for today, I think probably an emergency came up, and that's why the person, but I'm sure the person will send. So far, all those who have issues or challenges are doing very well. They send me messages and they fulfill their parts. Thank you.
Okay, so just important that we can catch up with our plan, but that's fine. So I think we're moving very fast. We're almost in 100 within the space of 3 days. If we can keep up with the momentum, I can bet you that within the shortest time we'll be done with Brownwood. All right, so we'll meet again tomorrow. Thank you.
Thank you, sir.
Yeah.
Thank you very much, sir.
Yeah.